So, hello everyone and good evening. I hope you all are doing very well in whatever part of world you are in this COVID pandemic. There were a few discussions about who is positive and who is negative among ourselves just before we went live. So I hope everyone is doing well and taking care of their family. I am Dr. Dakshesh Patel. I am a head and neck surgical oncologist at HCG Cancer Center, Ahmedabad, and I shall be your host today on behalf of Oncosurgery Master Course Edition 6, and I welcome you all. So in this era of webinars where the left, right, and center, everybody is onto attending meetings online where the shirts are nicer and the pants are pajamas, and discussing about all the topics we wanted to discuss in person, but will not be able to do this in this situation. But keeping it up with the ongoing tradition of OM, which is Oncosurgery Master Course, we thought in this 6th edition we'll try to explore some of the lesser known facts, right, which are the complications which everybody is reluctant to speak or discuss or present themselves on the conferences. But this is one of the good topic to discuss where we can share our complications and share the finer points, like how do we manage them. I like to share with you all that we have crossed around 1.5K 1500 registrations across the globe, and this has been made possible by the teamwork of the Oncosurgery Master Course 6. Just to give the overview about the Oncosurgery Master Course, the vision and efforts has been conceptualized by Dr. Kaustubh Patel and Dr. Rajendra Toprani, and those are the two our guiding heroes for all these years, and they are the organizing chairman as well. The event conceptualized by my course director, Dr. Dushyant Mandlik, and me. The background work, most of the work is being done by the organizing secretaries, Dr. Aditya Joshipura and Dr. Pareen Patel. And of course, there have been a wonderful scientific committee led by Dr. Purvi, Nitin, Dhanushya, Prashant, Ashay, Mitesh, and not to forget our fellows and the DNV trainees. The whole thing was designed, coordinated well by Mr. Sanjeev Dhawan, who is a man of ideas, and behind all those things which is being smoothly done, he is a member of ACF, which is Ahmedabad Cancer Foundation. We'll start this today's webinar, and there are some rules. As we all know, we are all habituated with this the new normal call thing. I request everyone to keep their mic on the mute mode unless they have to speak something. Right now, only the speakers or the host taking lecture only will be speaking, and whosoever wants to ask question can type the questions in the chat box. This today's webinar is about the laryngopharyngeal cancers. This is the 4th one in the series. The previous 3 ones were of the thyroid surgeries, oral cavity and oropharyngeal surgeries, and about the neck dissection. And the 2 remaining will be on the next subsequent Saturdays, which are on the salivary gland, reconstructive surgeries on the salivary gland and the osteoradionecrosis. Today will be dealing with the complications which we see about the laryngopharyngeal cancers. Now, the laryngopharyngeal cancers has been largely treated by the chemoradiation as well. So we have chosen 2 faculties. One will speak about the complications or what we face difficulties in the laryngopharyngeal surgeries, and the other lecture will be by the radiation oncologist, who will speak about the problems faced after the chemo radiation for the laryngopharyngeal cancer. So first, I will invite Dr. Prathamesh Pai, who is a professor and head and neck surgeon at the Tata Memorial Hospital, Mumbai, and he will speak about the special issues in the laryngopharyngeal surgeries. Over to you, Dr. Prathamesh.
Good evening, everybody. Dr. Your team at OM for inviting me to speak on this topic of complications following laryngopharyngeal surgery. I feel that complications are something that are inbuilt in surgery and something we need to discuss often so that we can avoid them. Many times we have heard from our seniors that all complications begin in the operating room. And this is very much true because every aspect of surgery leads us to a complication in the perioperative period. And one thing that I have always believed in, and the earlier we learn how to be delicate, how to understand what is the function of each tissue, the better we will be in treating our patients with lesser morbidity. Now, when you look at the laryngopharyngeal cancers, the surgeries involving these cancers have predominantly three complications. There are many routine complications, but amongst them, the pharyngocutaneous leak, the pharyngeal stenosis, and stomal stenosis stand out for the morbidity which they inflict on the patients and the outcomes thereof. When you look at the pharyngocutaneous fistulas, these are the most common complications, with the incidence varying up to 50% in some cases. And most of the post-operative period, anytime between 5 to 15 days. And occurrence of late fistulas is known after adjuvant therapy as well. So it's incumbent on us to know how to diagnose these fistula. Diagnosis is usually clinical. It is manifest with edema of the neck flaps, facial edema and swelling. Patient may have fever, and there could be tenderness of the skin incision. You can actually estimate the drain amylase or do a Condrey swallow to confirm it, but these are usually not required. Something appearing like this, tense, edematous in the postoperative period with a mucky drain would make a diagnosis of pharyngocutaneous fistula very ominous. So when does it occur? Usually between 7 to 11 days. And further progression of this, if not tackled in well, would be contamination with saliva, wound dehiscence, and a flap necrosis. You can do an elevated, test the amylase levels, as I mentioned earlier, in the drain sample when everything looks quiescent, but you're worried. And if you diagnose it earlier, you can actually manage it better. So how do you manage these fistulas? Majority of these pharyngocutaneous fistulas respond well to conservative management. However, there is no consensus on how much you would have to wait following a fistula. In our institute, we normally recommend 2 weeks of conservative therapy for a non-radiated tissue and a conservative therapy of 4 to 6 weeks if we have. Now, what does conservative treatment mean? It means you need to do a salivary diversion. Preferably, you need to remove the drains which you have put because they are non-functional. You need to put in corrugated drains so that the saliva is lateralized. You can give anticholinergics to reduce the saliva. You need to do a debridement of any tissue that is looking unsalvageable. You need to improve the nutritional support, give antibiotics. And if you feel that it is coming on to the tracheostome, you need to place a cuff tracheostome to prevent aspiration. You have to ensure that the tube feeding is maintained, and you need to have a proper care taken to other parameters as well. Often the success rate is between 50 to 80% with most conservative. Only and only if can consider. Now the question arises when to intervene surgically. As I mentioned, you would intervene if you have a tissue which is too large, the breakdown is too large, you have a very high output fistula and you cannot really control it for longer than 2 weeks. There's a breakdown of skin, or if there's a major blood vessel exposed, which could be a problem with a bleeding. So the various types of surgical repairs are dependent on the fistula. So you need to classify what type of fistula you're having. Is it a type 1 where the mucosal and skin can be closed primarily? Is it a type 2 where you can have a mucosal closed primarily, or a type 3 where you need both a mucosal and a skin closure? The most common types of flaps used are the pectoralis major myofibrotic flap. In these situations, usually you have a neck bed which is infected, and the recipient vessels are not actually suitable for a microvascular anastomosis. And hence, in acute settings, a free flap is usually not advised. However, in long-standing fistula where there is no evidence of infection, you can consider a free flap, a microvascular flap. Most important is to prevent this in the first place. And how do you prevent it? Evaluation, identify any predisposing factors, and have a proper surgical plan based on a careful evaluation. So what are the factors that affect a pharyngocutaneous fistula? You have the site and stage of disease. Glottic cancers tend to have lesser fistulas as compared to pyriform, where you need to actually resect the pharyngeal muscle as well. Stage tumors, T1, T2 requiring salvage versus the advanced stage T3, T4, they may be more predisposed to a fistula. The type of the pharyngeal remnant. If you have a pharyngeal resection which just requires a patch of pharyngoplasty versus the one that actually requires the entire pharynx reconstruction. So the ones that require complete reconstruction are more predisposed to a fistula formation. Prior treatment. Has the patient received radiation or concurrent chemoradiation? The more the treatment of with organ preservation, then what is the general condition of the patient? What is the nutritional status? Is the patient hypothyroid? These all factors need to be evaluated. Now, when you look at literature, this is a meta-analysis which has been recently published and looked at all the risk factors of pharyngocutaneous fistula following total laryngectomy. And they found that the patients who are above 60, smokers with COPD, or having a coronary artery disease, or having advanced stage tumors, those who had been radiated previously, pre-op albumin less than 3, preoperative hemoglobin on the lower side less than 10, patients with supraglottic or hypopharyngeal cancers, and the ones that are undergoing salvage surgery, these all are at a higher risk for a pharyngocutaneous fistula. So you know all these aware that your patient might be at risk for a fistula formation. So you need to prevent this by improving the perioperative nutritional supplement. See to it that the albumin status is corrected. Patient is not in a negative nitrogen balance. You need to consider perioperative antibiotics, and you need to improve your surgical techniques. In literature, there is no clarity whether a T-shaped or a linear suturing is better, whether a 2-layer or a 3-layer mucosal closure is better, whether the suture material makes a difference. But we need to improve our surgery. So what do you mean by tissue handling? So you need to, whenever we are doing a laryngeal resection, we are taught to preserve as much of mucosa as possible. But we tend to realize that you elevate that mucosa off the pyriform sinus and that becomes an unsupported mucosa. Very seldom we measure the pharyngeal remnant, and we just tend to close that because this is the fag end of the surgery, bilateral neck dissection, laryngeal resection, not just in a hurry to close. So what you need to do is see to it that all this unsupported mucosa is removed. So you need to, just by removing these few millimeters, you're not going to land up with a patch pharyngeal reconstruction. But if you do not remove this patient is a possible candidate for a fistula formation. So see to it, unsupported. And once you have done that, you need to measure. You need to measure and see how much of the pharyngeal remnant is at the oro-hypopharyngeal segment, at the midpoint, and at the pricopharynx. Generally, you should have more than 2.5 centimeters of unstretched mucosa. And this has been studied by the group from Queen Mary in Hong Kong. And over a 10-year period, they found that the ones that were having more than 2.5 centimeters of unstretched mucosa tended to not have stenosis or fistula formation. Now, how do you suture? What suture material you're going to use? There is no clarity or consensus in literature. But what is important is that you need to approximate the tissue without tension, without any strangulation of tissue. So you start and begin with a fixation stitch, and then you continue. There are some who do a submucosal closure and some who will do a full thickness closure. Both of which are valid. But what is important is that the mucosa should be inverted. There shouldn't be any exposed mucosa, which can inadvertently lead to a leak. So see to it that you have tension-free closure of the pharynx, which is of adequate width. And you do a proper closure all through. Now, should you actually use a muscle augmenting the pharynx? A case series of 1 year's data, and we realized that the amount of cases that we are doing as salvage is almost 40%. And then when we looked at whether we use a pectoralis major muscle, pectoralis major fascia, or a free tissue, you can see that the number of major leaks were higher when we used a pectoralis major muscle as compared to a free flap. Now, in relation to salvage surgery, we always are worried about a fistula formation. And in literature, we see that almost 21% of your patients following radiation can have a fistula formation. This is a systematic review of pharyngocutaneous fistulas following salvage total laryngectomy. And when they did an analysis, they found that the patients that were to have a better control or a lesser fistula formation. But you can see the total number of this systematic review was about 253 patients. So at the Tata Hospital, Shilpi Sharma and Dr. Chowkar did the analysis of the salvage patients, 172 patients, and we found that use of an onlay pectoralis major myofascial flap did not decrease the fistula rate. But what it did was it reduced the duration of the fistula. So that means we could offer these patients a PMMF flap, and the duration of the fistula reduced. So what I would suggest is to reconstruct your flaps, augment whenever necessary. If your remnant pharyngeal mucosa is less than 2.5 centimeters unstretched, please use a pharyngeal patch. Coming to pharyngeal stenosis. Now, after having done the surgery, you might end up with dysphagia. This incidence is almost 20% of all the patients who have undergone a hypopharyngeal resection, because you're actually removing a lot of pharyngeal muscle. And then if you're not actually measured it adequately, you might end up with a fibrosis following radiation, which then following surgery. Now, the etiology usually is an insufficient remnant pharyngeal mucosa, or if the patient has developed a pharyngeal fistula, and a postoperative radiation therapy. So as I was mentioning, this group from Queen Mary's analyzed 52 consecutive laryngectomies, and they concluded that 1.5 centimeters relaxed and 2.5 centimeters of stretched mucosa should be adequate for a primary closure and ensure no dysphagia in the postoperative setting. So we need to do that. Second most important thing is a myotomy, because if you have a stricture formation lower down, you can have a possibility of a fistula early on, and again that will lead to further pharyngeal stenosis. So suturing, see to it that your cricopharyngeus muscle is divided so that it will prevent any stricture formation in the postoperative setting. This also helps maintain your tracheoesophageal movement, and the speech quality and all will be better. So how do you treat pharyngeal stenosis if you should have it? Mild hypopharyngeal stenosis, you can do a progressive dilatation. If you have mature cicatricial narrowing, you can do a release of the or a replacement of that segment with a tubed PMMC or a FRAF. Coming to tracheostomal stenosis, this is something that is always worrying us in almost 30% of patients, and due care has not been taken during surgery, which results in this. And in literature, almost 43% of patients can have a tracheostomal stenosis. So the risk factors are a keloidal tendency. Female gender, usually 30% of them have invariably a smaller tracheal lumen. In patients who have a short, thick neck with excess skin and fat, a gland which has been left behind, hypertrophied sternocleidomastoid muscles, or if there are absent rings in the first place, which will predispose to buckling. Now, Montgomery has classified the stenosis as to a concentric stenosis, where there's a circumferential scar contracture, vertical shelf stenosis, where there's maybe a lateral encroachment of the sternocleidomastoid, or an inferior shelf where there's a redundant skin fold and a short, thick neck. Most of the times we get this concentric stenosis, and something which we can address. So you need to avoid the crowding into the space. You can see how the sternocleidomastoids are coming right here. We're forming a valley. You need to obliterate the dead space. So remove all the soft tissue around the stome so that the skin comes in contact with the tracheal rings. And you need to approximate the skin to the mucosa. So generally what we tend to do is a closure wherein the trachea is mobilized from below, and then you fashion the stome in a way that the skin comes into contact with the mucosa. You can see that the skin is completely covering the tracheal rings here. The second most important thing is to get into the junction between the cartilage and the membranous trachea. And once this stitch is taken, you can actually stretch the membranous part completely. So you can see in the next stitch, this is very vital. If this posterior membranous wall is not stretched, you don't get a proper D-shaped stoma, which invariably can contract later. Post-operative causes of a stoma is a salivary fistula, as I mentioned, benign scar contracture, or if there is a tumor creeping up later on. So when do you actually do a stomoplasty for a patient? When you have TEP maintenance issues. Normally you need at least 1.5 to 2 centimeters of stome or the posterior membranous wall in maintenance. So how do you do a repair? You can do multiple radial incisions. You can excise the scar contracture. You can insert the intervening skin like a Z-plasty or a double relaxation incisions. All of these actually go towards creating a release of the contracture as well as insertion of tissue between the trachea in order to get a complete stoma back. I think I've covered all the three complications, and I'll be happy to take questions in the panel. Thank you very much.
Thank you very much, Dr. Prathamesh. That was a very nice and lucid talk. I guess we'll take all the questions after this, the second lecture, which is by Dr. Sharbani Ghosh Lashkar. She is a radiation oncologist, professor at Tata Memorial Hospital, Mumbai, and she'll be talking on the chemoradiation complication in laryngopharyngeal cancers. Dr. Sharvani, if you can share your screen.
Okay, fine. So I'll just start. Can you see my screen?
Yes, madam.
Okay, good evening, everybody. To begin with, I would like to thank the organizers of the Oncosurgery Master Course, especially Dr. Kaustav and Dakshesh, for organizing this wonderful program. Over the next 15 to 20 minutes, I will be talking on chemoradiation complications in laryngopharyngeal cancers. The attempt will be to give an overview because the list is long and the time is short. So as you all know, the rationale for radiotherapy in head and neck cancers primarily could be either in the definitive setting, adjuvant, or as a part of combined modality management and effective palliation. The outcome that we are looking for then is effective disease control with improvement in disease outcomes, effective organ preservation with improvement in quality of life. But what we need to remember is that it is always a trade-off between toxicity and good tumor control. Now, if we talk about concurrent chemoradiotherapy in particular, it is the standard definitive treatment for patients with loco-regionally advanced cancers of the head and neck who are being considered for radical non-surgical treatments. It allows for organ and function preservation. And from the meta-analysis, we know that concurrent chemoradiotherapy can improve overall survival to the tune of about 6.5% over RT alone, with an improvement in disease-free survival and loco-regional control to more than 8%. However, what we also need to keep in mind is the acute and long-term toxicity of curative intent concurrent chemoradiotherapy, which entails a major health, psychosocial, and economic burden. Now, this is something that we need to keep at the back of our minds. The other point that I'd like to make is that from this paper by Soren, what we realize is that as we embark on more aggressive and more combined modality management, the burden of toxicity also increases, and this is quite obvious here. Of course, the grading scale that they've used here is a different scale that is not conventionally used in our OPDs. Now, the other fact is that we embark on chemoradiation essentially to see that we can preserve the organ and function in the patient. However, what I'd like to show you here is that in all these important organ conservation trials in the pre-IMRT era, what you need to see is that even with good controls that we see in the concurrent or the combination treatment arms, there is a definite increase, a significant increase in the mucositis, swallowing toxicity that is associated with the treatment arms. Also, what I'd like to point out is that there are several sequelae that we see after chemoradiotherapy in head and neck cancers. And to quote a few, these are the acute toxicity that are commonly encountered. The most distressing ones and the most common, of course, are mucositis and skin reactions. And of course, dysphagia or dinophagia with subsequent weight loss and acute xerostomia. We also see significant late toxicity, which occurs usually after 6 months. There is a tendency for underreporting when we are documenting late toxicity. There are various toxicity scoring scales that have been described in literature. Again, one of the most common ones that we use in the TCAE criteria, and lately we have the version 5. Of course, there are various objective tools also to assess these toxicities in our patients. The next thing is, as an example, I'd like to tell you about the magnitude of the problem. Now, the reason I have divided it into different eras is essentially to drive home the point that as we have seen evolution and improvement in surgical techniques, so also there have been changes that have occurred with radiotherapy. So most of the data that is quoted usually belongs to this 2D era. And then let's see what happens with the evolution of radiotherapy and technology. Now, one of the very important trials that we had, that was the RTOG 0129, most oftenly quoted for the HPV status. Now, if you look at this trial, the occurrence of acute toxicities in the conventional arm, that is the standard arm, which was 70 gray in 35 fractions with 3 weekly cisplatinum, you realize that there was a finite incidence of acute toxicities, and mucositis to the grade of 3 or 4 could be seen in almost 33% of the patients. Now, if you look at the late toxicities reported on this trial, again, what is quite obvious is that the worst overall grade 3 to 4 toxicity is also quite significant and is to the tune of about 21%. And the incidence of feeding tube at 1 year is almost 29%. Now, one of the most often quoted papers, especially by my surgical colleagues, is this paper by Michelle Macte. And this paper, because it brought into focus the issue of late toxicities that occur even after curative treatment for head and neck cancers. So if you look at this particular paper, it looked at the RTOG trials, a population of about 200 plus patients. And what they noticed was that 43% of accessible patients had severe late toxicity. And what was the kind of toxicity? If you look carefully here, there was toxicity grade 3 plus in both the pharynx as well as larynx. There were some deaths on treatment, so much so that the amount of toxicity was about 43%, which was in about 99 of the 230 patients who were evaluable for the late toxicity. It also told us a few risk criteria where we could or possibly preempt toxicity, and this was older age, advanced T stage, the larynx and hypopharynx as the primary sites. Also, what was noticed was that neck dissection after concurrent chemoradiotherapy was associated with an increased risk of these complications. Another important paper was the long-term results of the RTOG 9111, which was the 3-arm trial that brought into practice concurrent chemoradiotherapy. What was of concern was when the long-term results of this particular trial was presented, what was realized that almost 30.8% of patients in the concurrent chemoradiotherapy arm actually died of causes unrelated to cancer. There were no differences in the late toxicity or speech or swallowing function between the 3 arms, but there was an unexplained increase in the deaths unrelated to cancer. So all this data that we had of the 2D era actually brought into focus problems and the concerns that could arise because of the use of concurrent chemoradiotherapy. So now what we need to look at is, does this in any way interfere even with disease-related outcomes? One is the function, the other is, of course, disease-related outcomes. There is a loss of almost about 0.9 grade per day of interruption, which means that there is a 0.7 to 1.4% decrease in probability of local control for every missed day, 14 to 20% decrease in local regional control for a gap of 7 days. Now, how do we then go about elevating these problems or circumventing these problems? One is, of course, revising our practice by using various physical protection measures, medical prevention of mucosal injury and xerostomia, and is there a possibility of using any alternative to chemotherapy like targeted therapy? So if you look at physical protection, about which I will be dwelling in detail, we could look at beam modifying devices, beam collimation, treatment techniques which have evolved over the ages. So what we stand at today is the greater use of more conformal radiotherapy techniques by what we call as intensity modulation with photons and of course very recently with protons. So we used to in the old days shape our beams because we were aware that radiotherapy could cause unacceptable damage to the surrounding normal structures. Later on, this became dose sculpting with the use of physical blocks or with shaped blocks. And of course, now most recently, the use of intensity modulated radiation therapy. Now, what is the role of advanced technology in head and neck cancers? The target in the head and neck is primary disease and neck nodes. Conformal radiotherapy has the ability to reduce dose to the adjacent OARs without compromising target coverage, and this helps to maintain locoregional control with reduction in toxicities. It also allows for dose escalation and ensuring that adequate doses are delivered to the target structures without increasing local late toxicity, especially of relevance in locoregionally advanced tumors. And this is especially important when we are talking about multimodality treatment. The other thing that we need to understand is that on treatment, unlike surgery, which is a single setting treatment, remove what we see, but in radiotherapy, it's long-term treatment. There are changes that occur on treatment, changes in the target volume, because of which there could be movements in the OAR, patient loses weight. Now, advanced technology allows us to change the treatment on treatment, make changes in the plans on treatment. And this is just an actual view to drive home the point that there are several critical structures in the head and neck region, and which are closely abutting or closely surrounding the target structure. The other role is that it enhances, improves what I've talked about, locoregional control, theoretical possibility of dose escalation, and of course, two common late sequelae in radiotherapy are like xerostomia or dysphagia, and we can perhaps bring down the rates. And we'll look at some literature looking at this. And it actually attempts to reduce these sequelae and probably improves the quality of life. So what should be the general approach to any kind of sequelae to radiation or chemoradiation toxicity? Identify the problem, assess the severity, the structures of the processes involved, and the risk factors that may be responsible, prevent wherever possible by use of prophylaxis, hygiene, exercises, preempt. Now, with all this knowledge, we know what kind of patient may possibly end up having toxicity, what could predispose to the toxicity, and hence regular assessments on treatment and at follow-up are important. Protect, that is respect tolerance, optimize doses to the adjacent OARs during radiotherapy, and treat it easily and the sequelae, and maintain. It simply means that persistence of care after completion of treatment. So coming to some of the important and commonly encountered but very troublesome sequelae of chemoradiotherapy, the risk factors which are patient-related include extremes of age, poor nutritional status, poor orodental hygiene, neutrophil count before treatment, other non-cancer adjuvant medications that the patient may be on, and of course, continued smoking and alcohol consumption. Treatment-related risk factors include the dose and fractionation of radiotherapy, the volume that is treated, the overall treatment time, and the technique of radiotherapy. Drugs that we use concomitantly with radiotherapy, their sequencing, scheduling, as well as the method of administration are important points to keep in mind when we talk about chemoradiotherapy. Now, does this really have an impact? Yes. If you look at the study by Sanguinetti, 164 patients of carcinoma of the oropharynx treated with IMRT, 91 patients received concurrent chemoradiotherapy, while others received induction chemotherapy. If you look at what happened on multivariate analysis, what we found was that the only two predictors of acute mucosal toxicity was actually the weekly dose of to at least 21 cc of the oral mucosa and the use of concurrent chemotherapy. And these were two factors that not only act together, but act independently. And concurrent chemotherapy actually has the ability to increase the risk of mucosal grade 3 toxicity, almost about 4 times higher than radiation therapy alone. Other general measures that need to be followed include oral care, brushing with the appropriate kind of apparatus, rinse, avoid alcohol-based mouthwash, use water-based moisturizers, maintain various pharmacologic agents that can be used. We have palifermin, level 1 evidence to talk about its utility, cryotherapy, laser deposit, role for growth factors and cytokines, and of course, it is important to use radiation therapy in and modulate the fluence wherever possible. there's evidence to suggest that if we could restrict the dose to the volume of uninvolved mucosa and see that the dose that is the volume that is receiving 50 to 60 centimeter cube of water, a dose of more than 9.5 to 10 gray per week, it could possibly reduce and also decrease the dependence of PEG-2 feed. These are important consideration, and these are just some photographs to show you that it is possible today to monitor volume of tissue that receives the high dose, especially the adjacent uninvolved oral mucosa, can be protected adequately. Now, the other toxicity that we often encountered is skin toxicity, which occurs to the grade of 1 to 2 in almost 100% of patients, but severe grade toxicity should actually not be occurring. And this could be possible by seeing your patients appropriately, preempting reactions and taking the appropriate steps at the right time. However, we are normally using current therapy. We sometimes also use anti-EGFR antibodies, and which can cause a different kind of skin reaction, and we need to be aware and be able to preempt reactions. So what are the various factors, treatment-related factors, as well as patient factors, and how can we reduce and manage these toxins? Of course, depending on the grade, we could use various agents that are available, but the best thing would be to prevent, anticipate, and treat it appropriately. Now, coming to another very important sequelae of radiotherapy, and that is xerostomia. All of us have heard it so many times that we think any radiation would cause xerostomia, and that is true because majority of the patients who are treated with bilateral portals do end up having permanent xerostomia. And of course, the xerostomia or the parotid gland function is also a function of the radiation dose that the parotid glands receive. And parotid gland sparing has significant influence on salivary flow, and patients receiving less than mean dose of 35 gray have better salivary flow. And the main thing about xerostomia is that its effect is multidimensional. It leads to painful dry oral mucosa, impaired mastication, alteration of speech and swallowing, altered diet with malnutrition, an effect on swallowing, which simply means that all day-to-day acts of living are impaired because of xerostomia. So how do we manage xerostomia? One is to prevent xerostomia, appropriate salivary gland techniques have been described. The other thing today is the use of salivary gland sparing radiotherapy techniques like IMRT and brachytherapy in eligible patients. But since here we're talking about chemoradiotherapy, it is quite natural that we're talking of loco-regionally advanced disease, which are usually not amenable to brachytherapy. Now, treatment of overt xerostomia and its consequences, again, we would have to use various pharmacological agents and substitutes, but I would like to spend some time on how radiotherapy would help in decreasing the incidence of xerostomia. So as I've talked before, what we have seen that in radiation oncology, we've moved from these regular rectangular fields to normal structures. Now, this data looked at 3D CRT to IMRT. 60 patients, including all stages of laryngeal and hypopharyngeal cancers, evaluating 3D CRT with IMRT. The grade point was grade 2 acute xerostomia. What we saw was that there was a definite decrease in the incidence of grade 2 acute xerostomia in patients who were treated with IMRT. It resulted in significant decrease in the number of patients with more than grade 2 acute xerostomia. If we looked at the number of patients who had even late xerostomia, it was much lower in patients who received two trials at the same time. Again, what we saw was we had the primary endpoint of grade 2 or worse xerostomia. Again, what we saw was that in IMRT, there was a definite decrease in the number of patients who had xerostomia as compared to 3D CRT. The other important findings that we saw was that even in the long term, this remained true for IMRT and with a significant reduction in late xerostomia too. The other thing that we saw was consequentially, I guess, most patients had a less weight loss when they were treated with IMRT as considered as against patients who were treated with 3D CRT. However, what is most important is there was no compromise in the local regional control as well as overall survival. We also published a meta-analysis looking at 7 randomized controlled trials, which looked at comparing 3D CRT or 2D RT with IMRT. And the primary endpoint for 5 of these studies was actually reduction in xerostomia. And of course, IMRT behaved favorably in favor of reduction of xerostomia, and it was associated with a 36% relative risk reduction in more than grade 2 xerostomia at all time points. Of course, there is a possibility of reducing the dose to the submandibular glands as well as submandibular glands. Various surgical techniques as well as radiotherapy techniques have been described because this is the gland that is responsible for the resting feeling of wetness in the mouth. Another important consequence of radiation therapy was the impact on dysphagia or aspiration. And this is because of the fields that were used, the doses to the swallowing structures, as well as destruction by the tumor itself. What is possible today is to again shape and tailor our fields and doses to the structures. Now, what is the impact of chemotherapy? If you look at the various settings in which chemotherapy has been used, we can see that with the use of concurrent chemotherapy or even induction chemotherapy, there is an increase in the percentage of patients are swallowing dysfunction, and especially with concurrent chemoradiotherapy, almost 23% of patients are unable to eat solid food even after 1 year of therapy. And there is definite proof today to say that if you could reduce the dose to the swallowing aspiration related, the dysphagia aspiration related structures and keep the doses as low as possible, preferably below 55 gray, it would be possible to take care of dysphagia and aspiration to some extent. Most recently, of course, we have the trials of phase 3 study of dose optimized in dysphagia optimized IMRT versus standard IMRT by Chris Nutting. And what this definitely shows that with the reduction of doses, the various structures that are involved with dysphagia and aspiration, it is possible to have definitely higher MD Anderson dysphagia inventory scores, which simply means that these patients do better. And of course, there is the concern of having local recurrences in the vicinity of the safe structures is within acceptable limits. So what they concluded was that dysphagia optimized IMRT reduced RT dose to the dysphagia aspiration related structures and improved patient reported swallowing function compared to the standard IMRT. Of course, it is the first randomized trial looking into this. The other ways to reduce dysphagia would include delay feeding tube placement, or rather follow a principle of reactive tube feeding whenever possible. Consider NG tube feeding rather than gastrostomy feeding. Avoid even brief nil per oral intervals. Optimize psychological support and pain management. Set the goal of maximizing recovery by 6 months after RT that predicts long-term function for most patients. This is a summary slide showing the incidence of pre-IMRT as well as post-IMRT incidence of all these toxicities. Of course, on the block is protons. And then, of course, it also gives us the promise of being able to further reduce the dose to the adjacent OARs. Does it have an impact on quality of life? All these high-end techniques? Definitely yes. Again, our own study showing that there was no significant difference in the global quality of life, but certain other domains like dry mouth, sticky saliva, and mouth opening was significantly better with the use of IMRT. But what we need to remember is there is definite evidence to support the use of IMRT in head and neck cancers, but it comes at a cost. Essential to ensure appropriate QA and QC, adequacy of expertise and knowledge, time, labor, and cost intensive. I would like to conclude by saying that optimal patient protocols, more attention and awareness is necessary, and especially documentation of toxicity. Strategies for possible toxicity reduction include attention to supportive care, optimal radiotherapy technique, doses, and fractionation. Avoid unplanned interruptions if the intent is cure. Quality assurance exercises and audits are essential. Verification protocols in radiotherapy are as much should not come to the session. Thank you very much.
Thank you very much, Dr. Sharbani, for the nice evidence-based lecture on the complications and the ways to have a control on them. So we have few questions here for Dr. Prathamesh Pai and Dr. Sharbani as well. Dr. Prathamesh, are you with us?
Yes, I am.
So the first question is by Dr. Mayuri Rajapurkar. She asked, in which cases do you recommend the salivary bypass tube, and when do you recommend not using them?
So in practice, we do not really use salivary bypass tubes, but in literature, there has been several studies which have looked at the use of salivary bypass tubes, but there haven't really made a difference in the outcomes. The fistula rates are the same with or without the salivary bypass tubes. We do not have any experience at the Tata Hospital with the use of these, but I do hear a couple of colleagues mention that they are using it routinely. So if someone who's there in the audience and has experience, we need to ask them.
Thank you for that. The next question is from Dr. Pushpendra Hirpera. He's a radiation oncologist at HCG Bhavnagar. And I guess the question is for Dr. Sharbani, madam. He asked, which are the subsets of patient where you would advise to keep radical doses, that is at 66 gray, at 2 gray, and not the 70 gray? Is there any relation with HRCTV volume or dose to OARs like constrictors, or do you, or you would like to plan all patients at 70 gray?
So Pushpendra, the aim of any radical treatment should be to give your highest possible dose, that is 70 grain 35 fraction equivalent. Now, whether you're giving 66 grain 33 fractions or you're giving 70 grain in 35 fractions, if you want to cure, you will have to give 70 grain 35 fractions. I do not think we change the dose if you are giving curative intent radiotherapy because of the dose that is received by the dysphagia aspiration related structures. What I would like to tell you here is that the dysphagia aspiration related structures need to be contoured. You need to document the doses, but I don't think you have to reduce the doses. There is no such recommendation just because that is receiving a high dose or that is becoming a part of your target volume. Please do not contour or edit your target volume to remove it out of your dysphagia aspiration related structure. I hope it answers your questions.
We'll be discussing it more during our panel.
Sure.
Yes. So there is a few more questions. One is by Dr. Mudit Agrawal to Dr. Prathamesh Pai, I guess. Which flap to choose for patch pharyngoplasty? Is it free ALT or FRAP or a PMMC? That is the first question. And second is, when do you start feeds after salvage?
Actually, can we take these questions during the panel, because these will be otherwise answered now by the speakers itself, and then there won't be any questions left for my panel.
Yes, so I have seen your presentation as well, so I try to ask questions which are not in your presentation. The light has gone.
Okay.
So there is one.
So maybe we'll keep that for the panel, Dakshesh.
Okay, great. Okay. So thank you very much, both the speakers, for the nice presentations. And now we'll go for the next part of our webinar, which is the panel discussion. The moderator for the panel is Dr. Rajendra Toprani. He is a senior.
Dakshesh.
Yes.
Yeah, Dakshesh, Kaustubh here. What we can do is you can keep a track of those questions.
Right.
After end of the Toprani's moderation, if these questions are left behind, then the faculties can answer it. You know.
Sure, I'll do that.
Okay.
So the moderator for our panel is Dr. Rajendra Toprani. He is a senior head and neck surgeon at HCG Ahmedabad. He is the president-elect of the Indian Association of Surgical Oncology, and we'll be covering the same topic, complications and how to manage them, how to prevent them in the treatment of laryngopharyngeal cancers. And I would request Dr. Toprani to introduce our panelists as well. And I would request Dr. Prathamesh and Dr. Sharbani also to remain in the panel, and Professor Shaha, I think he's also there. I would request him also to remain in the panel.
Can I start sharing my screen?
Yes. We can see your screen now, Dr. Toprani.
So thank you, Lakshesh, and I think we have got what 1 hour.
Yes, and you can extend also if everybody is interested.
Yeah, so it's now up to 8:30, so 1 to 1.5 hours, whatever is convenient to you.
Okay, so we have a very great panel today with us, and we are joined by Pankaj. Is not there, I think. Is Pankaj joined? Okay.
Yes,
so
Rajesh, I'm here.
Okay, so Pankaj from Tata Memorial Hospital, then Saurabh from Delhi, we have got Tapaswini from Delhi, we have got Dr. Shinoy from Bangalore, and probably is in UP now or Bihar, Dr. Shinoy. And we have Dr. Vishal from Bangalore. For radiation oncology, we have got Dr. Samir Batham from HCG Ahmedabad and Dr. Ashish Kaushal, medical oncologist. We don't have any other medical oncologists on the panel or in the audience probably. And Sarbani and Pratmesh, of course, are there, and Dr. Shah, of course, to give any expert comments. So I think everybody is available, and then we can start discussing on this panel.
Excuse me, can I say something?
Dr. Uma is there, Umanath.
Oh, sorry. I forgot. Your name is missing from this thing, so maybe it is my mistake. So Dr. Uma from Hyderabad is also there. Okay. It doesn't move. So this sentence by John Connolly is so apt, so appropriate for laryngopharyngeal cancer treatment complications. So some complications are unpredictable even now in this era also. Some complications are unpreventable, whatever you do, and some are incurable. So it is so aptly told by John Connolly so many years back. But having said that, the best thing what we can do, how we manage this complication is to prevent them, to identify the risk factors. So let us see what we need to understand about these complications. I'm not able to actually move the slides. क्या थी करो एरो की थी करो एरो की अच्छा
Right click भी करवाना है।
हाँ नहीं दे
हाँ चले तुम कैसे करोगे?
हाँ
Up down.
ओके
Mute है पहले जैसे।
So from 1990s, primary total laryngectomy has remarkably decreased till the present day. And at the same time, simultaneously, the salvage total laryngectomy has remarkably increased for residual or recurrent disease, as well as for the non-functional or dysfunctional larynx post chemoradiation. So we all understand and accept that non-surgical management is the standard of care, except for patients with gross cartilage erosion or extralaryngeal extension, or who are medically unfit to undergo chemoradiation concurrent treatment. So my questions to all the surgeons in the panel, and what do you think is the incidence of how many of you do primary total laryngectomy and how many of you do salvage laryngectomy in your practice? Just a quick answer, all of you. Pankaj, you can start.
So
What
thank you.
percentage of your total laryngectomies are primary still, and what percentage are salvage?
Perfect. So almost 3/4 of our laryngectomies are primary total laryngectomy, and 1/4 of them, and the number is increasing. Like I remember 15-20 years back, they were predominantly primary laryngectomy, but the proportion of salvage laryngectomy, which is 1/4 today, is increasing.
Uma?
Ours is the reverse. In fact, we have 75% who undergo salvage and maybe only 25% primary.
Vishal?
So the same figures, more than 80% of our cases are salvage, and only about 20% come in the advanced stages, sir. And there also we see that more of the government schemes, when we also do government schemes, those we see more of them who are coming in T4 in the primary presentation. More of the well-educated affluent classes come in the early stage and go towards salvage, those ones in T1, T2.
So let me rephrase this question. Maybe I have asked the question in the wrong way. How many of your patients who are fit to undergo chemoradiation, you still do total laryngectomy in your practice for whatever reason? Patients are not ready, or patients are medically unfit, or you have to do a salvage?
Can I answer that?
Yeah.
Basically, elderly patients, say above 70, which may not be an indication for CTRT. Whenever a patient we feel that may not be able to sustain chemo and he is T3 or T4, we would prefer primary total laryngectomy, whether larynx or hypopharynx.
So you decide in a tumor board meeting about whether this patient is fit for chemoradiation or. What about
so Dr. Toprani, I think it is.
What is the scenario in Delhi?
So 3:1. The first question, and when you phrase it for that, 3 for the salvage and 1 for the primary surgery, primary laryngectomy. The second time when you ask the question, it is more we have to ask to the patient. Is the most of the time it is a 50% the patient decision when we counsel them. More than 70 years of age is a age. If the patient is fit enough to take a chemotherapy, we give chemotherapy up to 73, 74 year age also. It's not like that if the patient is more than 70, we will not give patient with the T3 larynx, not give the chemo RT to that patient. Most of the time, the tumor board decision are the evidence based, but that when you have to take the decision like this, in those cases, it's the patient counseling is very important. What patient wants, because these patients sometimes go for the radiotherapy with the targeted therapy also with the Vitex.
Toprani, can I make a comment here?
Yes.
Having been at all our T4s go for surgeries. T3 is an area where I think it depends on the patient and the physician. And now that I have come to an area where I have no longer the amount of load that I used to have in the earlier institution. Nevertheless, it is a teaching hospital, and I can counsel the patient and go ahead with a process which removes a speech restorative laryngeal surgery for T3 and less. So I still keep that open, not T1 and T2. T1 and T2 just go for the usual radiation.
Can I make a point here?
Yeah,
Yes,
please.
yes, Sarvani.
You know, in a thing as Ankit said, most of our patients would be seen in the multidisciplinary clinic, and that's a large proportion of patients. So what happens is that typically what we look at is, as Saurabh mentioned, the age, the performance status, and the laryngeal function. Luckily, now we've got a very active speech therapy, speech language pathologist. So we are able to assess objectively and symptomatically the patient's objective functions of the larynx and then make the decision. So I guess that is why our proportion seems to be a little different, but then we have a very low threshold for giving concurrent chemoradiotherapy for patients who have a dysfunctional larynx. So typically the T4s in our situation who undergo laryngectomies are those who have the cartilaginous framework is destroyed, and they have obvious aspiration. Even T3s with obvious aspiration will not come onto a organ preservation protocol.
Yes.
So Tapaswini, what is the practice pattern in your hospital? Is Tapaswini able to hear me? She is not. Samir, can you tell what is happening at our center? I think we treat more or less all patients who are fit for chemoradiation with chemoradiation and don't give total laryngectomy as a first option to them.
We also give most of our patients, they go through the MDT, and most of the time we treat them with CTRT only. And I agree that age alone itself, we haven't considered that much. We have treated patients more than 70 also with radiation plus minus chemotherapy.
Yeah, but at the same time, I think all surgeons on the panel will understand that from 1990s, when chemoradiation was popularized and we started treating patients non-surgically, then we learned how to operate these patients post-chemoradiation. And it was a very challenging and a difficult problem. And I think the incidence, the proportion of total laryngectomy in our practice as far as salvage total laryngectomy is concerned is definitely increasing. All of you do agree? If you have anything else, otherwise we go ahead.
Sir, just want to make one point. I think the point Dr. Sarbani made about age, comorbidity and functionality, especially in the area where you see dysfunctional larynxes at presentation, whether it is because of a tracheostomy, whether it is because of aspiration.
Yeah, we will come to that. We will come to that, Vishal. But what I wanted to understand is definitely salvage laryngectomy has been common operations now, which was very uncommon earlier.
Yes, sir.
So now it is becoming more and more common in our practice. So,
Dr. Toprani?
Yes, Tapaswini, you are mute since a long time.
Yeah. No, I think one of the main reason why salvage laryngectomy has become, the number has increased is probably because of inappropriate selection of our patients for organ preservation. A lot of us, of course, whenever there's a cartilage invasion, everybody is clear about the fact that this has a surgical case. But when it comes to an organ preservation protocol, other than a dysfunctional larynx, the tumor distribution also may be such that you feel that at the end of the treatment, this organ probably would not be, like suppose if you have a huge circumferential growth and you feel after the treatment there may be more chances of stricture and all. So it would be preferable, prefer to a surgery rather than subject them to chemoradiation.
Dr. Toprani, I agree with Tapaswini. We also find that undue pressure on these patients to undergo organ preservation. And this is without proper evaluation of the volume, without evaluation of the patient's need and the ability to withstand. So that is why we feel that the incidence of patients requiring salvage is so high.
So this is also reflected in, I went through so many of papers recently, and the incidence of patients needing tracheostomy and feeding tube support post chemoradiation was so high in some of the studies. More than 55% is a big number. Yes. And we don't see this in our practice actually. So I don't know what is happening with some of the studies. So we will come to that. But that is a concern. If more of your patients are not going to have a functional larynx at the end of your chemo radiation, it doesn't serve the purpose. So my question to Ashok Shinoy and Umanath and all, do you still do a lot of near total laryngectomies and in those T3 patients, or would you now have you changed your practice and refer those patients for chemoradiation? Shinoy, I remember in Calcutta when I met you for the first time, you presented a series of 200 plus near total laryngectomies when I presented an open supraglottic laryngectomy paper. Do you still aggressively pursue partial laryngectomies?
Yes, the issue is that it is the onus of the surgeon and the team to set a practice. For instance, I believe at the place that I was practicing for the last 3 decades, it is still predominantly a larynx predominated primary surgery. However, having come to a new center here at Patna, Bihar, which is not, we don't see too many larynx here. So I have done a few partial laryngectomies, but I have not got those that are T3, which are very, which are too advanced for partial laryngectomy, and in whom a total laryngectomy would be considered an overkill. So I have not seen that kind of patient. So I don't want to push the procedure just to get numbers. So I don't see those kind of patients anymore.
Pankaj, what has happened at TMH over last 3 decades? You are also doing a lot of open partial laryngectomies, and then gradually we change to chemoradiation for such patients who are even fit to undergo near total laryngectomies or otherwise.
Correct. So there are 2 aspects.
How this has changed? Why this has changed?
So there are 2 aspects. One is whether we are doing NTL or not, and whether we are doing open partial laryngectomy or not. Now, talking about the NTL, I agree with Dr. Shenoy that there was a time when there was a problem with the tracheoesophageal puncture, and then having good prosthesis and good voice rehabilitation. Now, what has happened these days, the type of prosthesis, especially the Provox that we have and the primary TEP that we can do, and can give 90% patients the voice rehabilitation, that has really given a level of comfort to the surgeons in doing total laryngectomy. The only advantage of doing NTL was the biological maintenance-free shunt, but unless it is done in an expert's hand, the shunt stenosis or shunt aspiration was always a problem. And unless you have done 3 or 4 of them yourself, you cannot never master the technique of doing NTL. Now, talking about the open partial laryngectomy like supracricoid and others, certainly it is on decline because we have wonderful radiotherapy facilities now, and we are able to conserve those indications through radiotherapy. So that indication for primary supracricoid partial laryngectomy has gone down. However, whatever supracricoid is being done now is being done for salvage in tumors rather than in the primary tumor setting.
Dr. Shah, can we get a viewpoint from the USA why this near total laryngectomies or partial open laryngectomies are not popular at all now, or it was not very popular at that time also, and why majority of the patients would be treated with radiation?
Yeah, it never became very popular either at Memorial or in United States. It's actually started by Bruce Pearson. He was in Jacksonville, and he was a master surgeon. And his idea, just to give you the understanding, was when we do total laryngectomy, our focus is to take the organ out. When you do subtotal or Pearson procedure or near total laryngectomy, the idea is to take the cancer out and leave the normal mucosa, develop an internal shunt. Now, what happened was over shunt, S-H-U-N-T, which is the speaking internal shunt. Now, what happened over a period of time, this was the era before concurrent chemoradiation or organ preservation thoughts. As we learned more about organ preservation, the subtotal laryngectomy went out of picture. That is number one. Even in India, if you look at the history in India, Sultan did a lot of subtotal laryngectomies, Pearson procedure. In Brazil, it was popular again before 1990s because we were not using organ preservation. As we learned that some of these patients who required a subtotal laryngectomy could be easily treated with chemoradiation, and their salvage rate was, their control rate was high, they preserved the function. As we mastered the philosophy of organ preservation, starting from VA studies and many more, we realized it's not the preserving the organ, it's the control of the cancer and preserving the function, which was very important. And I think over a period of time, we learned that we are subjecting some of the patients to chemoradiation or radiation or organ preservation without due consideration of the initial extent of the disease. And then we realized in the MDT that certain patients are not best candidates for organ preservation. And those are the ones which was described before, like massive disease. And I like to divide the advanced thyroid cancer into advanced laryngeal cancer into advanced and very advanced. The very advanced are the ones which cartilage destruction, massive tumor, those which require emergency tracheostomy, parapharyngeal disease, paralaryngeal disease, or extension of the disease massively in the subglottic area or in the base of the tongue. Those are not ideal candidates for organ preservation. And those are the patients who will suffer because their larynx is going to be dysfunctional. They don't eat, they don't speak. And when they come for secondary surgery, salvage laryngectomy, the complication rate is high and the control of the disease is very poor. So this is the whole history of subtotal laryngectomy. We don't do those very often. Just to give you one more perception, in France with Olivier Lacourier, the supracricoid laryngectomy became very popular. Another way of considering conservation surgery. Remember, there is a conservation surgery to preserve the function. And it became very popular. Greg Weinstein came to UPenn and he popularized it. But again, over a period of time, it went out of vogue because the patients who went for supracricoid laryngectomy could be easily treated with chemoradiation or with an organ preservation protocol, and our results were very good. So it became very unpopular in the United States. Some of the bold surgeons used that after organ preservation protocol, and they had disasters. The separation, the wound infection, the carotid exposure. So that operation also became unpopular in the United States. So just to summarize, the Pearson procedure or subtotal laryngectomy is unpopular. Supracricoid laryngectomy is also unpopular. And what is important is, as Sarbani said, you need to choose the right patient for organ preservation. And if you do that, your outcomes will be much higher.
Yeah, thanks for giving an insight into the history. And my next question is to
Toprani, can I intervene?
Yes.
Yeah. So, here, when I hear all these things, I feel that, near total laryngectomy is now obsolete. I have to it and I still practice near total laryngectomies, but my indications have changed. To me, I think today a strong indication would be a patient who has a dysfunctional larynx because of the right hemilarynx fixation. If the opposite larynx and interarytenoid region is absolutely normal, rather than doing a total laryngectomy, I would still offer him a near total laryngectomy after counseling, because the cost of TEP and also the complications of TEP are almost equal. I mean, the complications are almost equal to the failure of near total laryngectomy shunt functioning, and the cost is much more in Indian context. So there can be, this surgery needs to be mastered by a head and neck surgeon. I would say that this is not a surgery to throw into a dustbin. And there are still indications in a high volume center where people are trained for doing near total laryngectomy. There are definitely some indications. The indications have reduced, but it has not become obsolete. Even today, we do near total laryngectomy in select subset of patients. We have done it for pyriform fossa, even for salvage also. For a salvage near total laryngectomy for a pyriform cancer, we have done it. So
you have made a good point, and these surgeries need to be in the armamentarium of a head and neck surgeon, and they do come handy in selected patients. Having said that, in all your centers, this is a question for all the panelists. When you treat your patients with chemoradiations, how many of them end up with a dysfunctional or a non-functional larynx?
Nearly about, I think, about a third. At least 1/3 of them will have aspiration.
We'll just move with the one crisp answer. 1/3 from Shinoy, then at TMH.
So, Rajendra, our dysfunctional larynx is quite low, and let Sarbani tell you the exact number. Because as I told you, our proportion of the patients who go for CT-RT are very appropriately selected, and that is why
for those who undergo chemoradiation at TMS, yes, how many actually end up with non-functional or dysfunctional? Sarbani, you have some number with you?
It would be around 15 to 20% who end up post. And if they had a pre-existing, that's a different number.
No. We are talking about post chemoradiation. So Saurabh and Tapas,
it would be just
Saurabh and
around
Tapas,
15% or so. Yeah.
So 20%, the same thing, because all patient goes to the tumor board and we have a selection criteria that like subglottic extension, we don't take those patients for the chemo.
Yeah.
So there are some criteria.
I want an answer about the number.
15 to 20%, and very.
It's around 30 to 40%, I should say. Okay. Because most of the patients whom we are treating for a total laryngectomy have actually been treated outside. So I really don't know whether they were appropriately selected or not. Were they actually assessed properly?
Another important point you are bringing up. Patients who have been radiated at other centers, you don't know, and what drugs have been given, and probably
honestly
that may contribute.
So these figures may not be really. These figures may not be really corroborating with others, but then it depends upon what sort of a center that you're working in, what are the type of patients you are getting.
Dr. Uma?
Yeah, about 10 to 20%. Our problem is not dysfunctional larynx, our problem is dysphagia. Dysfunctional larynx is not that big a problem for us after CT-RT.
But dysphagia, when you say dysphagia, then they will need feeding tube support?
Dilatation most of the time. Feeding tube support sometimes.
So they would be what?
Regular dilatations, yes.
They would be 10 to 20% of all patients treated for chemoradiation?
Dysphagia is more, I said, about 1/3.
1/3.
Whereas dysfunctional larynx would be 10 to 20%.
And Vishal?
Yeah, Dr. Toprani, the dysphagia is more, that definitely 15 to 20%, but the needing feeding tube only 5 to 5%, not more than that.
Toprani, I have one question. You have something called the Laryngo-Hypopharyngeal dysfunctional index, and this can occur if you have aspiration. Alternatively, it can happen when you have a dysphagia. The causes of either of these two morbidities are different. So, but they are certainly diminishing the quality of life on the patient. Another important parameter which we have not discussed, and I would like to you to address it amongst the panelists, is when there is a disease failure plus a dysfunction. And this is what I am worried about more than anything, because in this case, a salvage laryngectomy becomes important to save the life. So I would like to know this figure, if possible, from my colleagues.
Yeah, we'll discuss that also. Vishal, what is the number in your practice, incidence of dysfunctional or non-functional larynx post CT-RT?
Sir, roughly around 10% to 15% they come with minor and 5% of them
all
come
of
with
you have
major.
told me 10 to 20% in general, except Tapaswini 30 to 40%. So this is definitely a serious problem for all the surgeons in our in India, in majority of the cities. Now, Sarmani, tell me, why does this happen? Why the problem of dysphagia and aspiration and all this happen because of radiation? Is it because of some mechanical problem occurring in the larynx, or how does it happen actually? I have enumerated 5 things here: reduced base of tongue contact with posterior pharyngeal wall, and decreased laryngeal elevation, and higher anterior movement is reduced with decreased vocal cord closure and decreased vestibular size. So is it what leads to the dysphagia and the stridor and aspiration?
So if you look, we have a publication on this. Actually, Dr. J.P. Agarwal is the lead author. And if you look at the paper, you realize that actually all aspects of the swallowing function or the swallowing mechanism are impacted by radiation. So that is why if you looked at my slides, what I did was dividing them into the pre-IMRT era and the post-IMRT era. The reason being that despite all the advances that have happened, the ground reality is that even now in the general population, almost 60 to 70% of our patients still get conventional radiotherapy. And that's essentially leading to an element of dysphagia, which is bound to happen for multiple reasons. The other reason is that even when we do IMRT, we have to be careful about what we save and what we treat. Now, if you ask me what is the cause is that radiotherapy impacts all those, the list that you had shown, it impacts all those parameters. But what we have to do when we are practicing radiotherapy or when we're treating the patient is, first of all, selecting the patient right. Second thing is that defer tube feeding if not absolutely necessary. So that is why we typically follow a principle of reactive tube feeding and encourage the patient, if he or she is not obviously aspirating, to take orally as far as possible. And the third thing is that we also encourage patients to follow and meet the speech and language pathologist and simple speech swallowing exercises.
So we will come to the preventive aspects and all. But let me start this by asking the surgeons. So many things have been told about selecting the right patient. So how do you select the right patient? We are not talking about selecting T4A or T4B patients here, of course. We are talking about T2 or T3 with N+. So that makes it stage 3 or 4. So Saurabh, how do you select your patients? Whether you will select all T3 patients or what subset of T3 patients you will not select for a concurrent chemoradiation protocol? Your voice is not there. You're muted.
You're muted. He's muted.
Yeah. So the number 1 is the tracheostomy, but the tracheostomy where the tracheostomy has been done to prevent aspiration. Those patients. I
would appreciate just crisp answer so that we can make a round.
Okay. Tracheostomy for aspiration, extensive subglottic extension. If there is a minimal cartilage erosion, we take the decision with the patient and radiation over tumor board, and with that patient counseling that you have both the option, you have more chances of failure. If the patient say that they want to go for chemotherapy, that is fine. So these are and if there is a very bulky disease, in those patients also we give the option of laryngectomy to those patients. So this is for larynx. I am not talking about the hypopharynx.
You made it a point to say tracheostomy for aspiration, so that rules out that patient completely. What about those patients for who have undergone tracheostomy for stridor somewhere in the peripheral?
Yeah. So see, my philosophy for that is, if you have to take out the eye, if there is a dysfunctional eye is there, that is give the psychologically advantage to patient. The aspiration is different, because where patient can't speak even with the tracheostomy. If for the stridor, the tracheostomy has been done, patient can speak with if the patient disease is not there, still he can speak with the non-cuff tube.
Dr. Uma, you have a separate philosophy?
Yeah, let us accept that in today's scenario as surgeons, CTRT for a T3 cancer is the default treatment. whether you like it or not as a surgeon, but that is the default treatment. And then you have to decide amongst those patients, which are the ones which may not be suitable. Now, it is not just, you may decide that this patient is a candidate for surgery for whatever reason, but it is not that easy to convince the patient. In a private setup, for example, you may tell the patient that you will be better suited for a total laryngectomy, but he will go to different doctors, he will go to radiation oncologists, and ultimately he will go and get the treatment with radiation generally. But if a patient like Dr. Saurabh said, he has a tracheostomy, he's already suffering, he has got secretions coming out, and this is a dysfunctional larynx, it's much easier to convince these patients that surgery may be better for you. So there are certain situations wherein patient himself agrees to your treatment, whereas there are many times you try to push a patient T3 larynx for surgery, and ultimately he will land up in the radiation oncologist's hand. So that's what you have to accept as surgeons. That it is, rather than them going against you and getting a treatment, it's better that you encourage them to get a CTRT treatment if it is a borderline situation, because you can always salvage them later. Maybe not with the same results, but you can.
Yeah. So, Pankaj, my specific question is, if a patient has undergone tracheostomy for stridor, not for aspiration, as Saurabh said, will you still treat this patient with chemoradiation at TMS?
So it all depends upon the case-based discussion, and these patients will be taken for tumor board, and that answers Umanath Naik. See, if the surgeon and medical oncologist and surgical oncologist and radiation oncologist are sitting together and convincing the patient, that is where the whole, patient gets convinced. Now, coming back to the tracheostomy thing.
In other words, what is the chance that a patient who has undergone a tracheostomy will regain the function post chemoradiation and will be
correct? So many a times we do tracheostomy for supraglottic lesion like epiglottic lesion, which is falling like a valve on the laryngeal chink and causing the problem. And those are the patients which would be benefited by CTRT even if they have tracheostomy. But if we have done the tracheostomy for narrow airway in patients with glottic cancer, transglottic cancer, piriform cancer, very unlikely that after you have done your larynx preservation by chemo RT, they can be weaned off tracheostomy. So and that is why it is a relative indication for laryngectomy.
Yeah. So it is very important for us to differentiate as surgeons what is a non-functional or a dysfunctional larynx to begin with, and exclude those patients from chemoradiation protocol to begin with. Am I right?
Yeah.
Can I make a comment, Toprani?
Yes, Shina.
Yeah. I think if you know that it is an exophytic lesion, like Pankaj is saying, these are the people who form the cohort which gave a huge successful thing in the RTOG 9111. These were the exophytic supraglottic tumors. However, the ones that fail are the ones which are glotto-subglottic, where the down part, the subglottic part, is full of hypoxic cells, and where the chance to go through the cartilage is very high. These are the lesions, if I observe them, that the success rate for larynx preservation is nowhere near the RTOG 9111. So we need to stratify those are exophytic, which are nicely oxygenated. There's a cauliflower type, and these probably even at T3 and early T4A coming out through the thyroid membrane may respond to CTRT. But the ones, if you have a T3 lesion going from glotto-subglottic coming out through the cricothyroid membrane, these people will, and it's circumferential, I don't think these will do. So these are totally different categories of tumors that we need to look at.
One more category is an infiltrative disease, a transglottic lesion involving the erythenoid with an intererythenoid edema, and patient having microaspiration when you see on a Hopkins examination. This kind of probably will not tolerate chemoradiation.
They will not tolerate. They will not tolerate.
And Samir, do you agree to this? How we select the patients from the surgical side and discuss in the tumor board? Do you agree that this patient should not undergo chemoradiation?
Yes, I think I agree to the fact that if they are infiltrative growths, transglottic growths, subglottic, they would not be the ideal candidates for organ preservation.
So what we commonly say is a fixity of the hemilarynx with inter-arytenoid edema and all. So these patients will have a lot of swallowing issues, and they'll be dependent on tube feeding, and they might end up in a permanent tracheostomy also for a lifelong also. So these patients we should exclude. So this message should go loud and clear to everybody who is attending this. Please select your patients for chemoradiation very well. Discuss in your tumor board meetings and go ahead.
Dr. Toprani, I have one point as well.
Assessment of function.
I need to. Can I speak?
Yeah.
Yeah, Dr. Toprani, what we are also discussing is a group of laryngeal cancers. All the laryngeal trials done so far have been laryngeal. And what we are seeing is supraglottic and hypopharyngeal cancers, which are marginal zone cancers.
Yes.
So really, we are putting all of them into one basket without trying to differentiate a laryngeal from a hypopharyngeal or supraglottic cancer. In our group of patients, these are the patients who will not really benefit because they are very large volume. They tend to have exolaryngeal spread, but still preserve the cartilage or the framework of the larynx. And these are the group of patients that end up getting salvaged. So we need to actually differentiate very carefully. Are we dealing with a glottic tumor, which is T3 with a impaired cord mobility, or are we dealing with a pyriform cancer, which has gone into the larynx? And these are the patients who may not really benefit. In level 1 evidence today is to offer these patients neoadjuvant chemotherapy, select out a group that is not responding, and then offer them surgery. But this is not happening. Everyone today puts them into one bag, and these patients are offered chemoradiation. So, of course, over the last 2 decades, I have seen that there is a transition. We are seeing less of hypopharyngeal cancers and more of glottic cancers. But please understand the difference between these two subsets before planning organ preservation.
So your message is for T3 pyriform fossa cancers. Be very selective. You are selecting your patients for chemo.
Right. Volume makes a difference, but we still don't have enough of clarity on what is the volume that will benefit from chemoradiation. So we need to work on this.
Dr. Toprani, can I just comment?
Yes, Tapaswini.
Yeah, so I fairly agree with Prathamesh, the various points that he has said. Now, just before him, we were talking about patients who have been tracheostomized prior, and can they be clubbed? Can they be offered chemoradiation? So the point of debate was coming on to exophageal growths, forming a ball valve effect, and so on and so forth. So this is the point which I wanted to clarify and tell. If a patient has had a requirement for a tracheostomy, it actually does suggest that the larynx to great extent has become dysfunctional. And even if we try preserving the larynx, it may not be a functional larynx at the end of the day. Because here we are again talking about volumes. So if it's a huge exophageal growth, which has actually led to a respiratory discomfort and a patient landing up in tracheostomy, so this patient may not be really responsive to a chemoradiation protocol as well. So this was just a point because I have seen many people getting tempted with the fact that this is an exophageal and that is why
A
our
lot of
tracheostomy
background
is
noise. Somebody is having a lot of background noise.
Rajendra, I have one more tangible data,
those who are not speaking.
tangible data which was published by Suresh Mukherjee from the Gainesville group. He quantified the volume of the tumor, and if he said that if it is more than 3.6 cubic centimeter, and this was with respect to radiation alone, and the curve goes down after 3.6 cubic centimeter, the curve goes down. Later on, there were some studies done with respect to radiation and chemotherapy, and they found a new kind of a ball mark, a end mark that showed that if it is less than 3 cubic centimeters, the chances of having a control with CTRT is less. So you can have these tangible parameters which are much better and much easier for people to evaluate with a CT scan. in addition to your clinical evaluation.
Yeah, point well taken. Samir, you want to make any quick point?
So, just a comment on what Dr. Tapaswini just mentioned, that the ma'am, many times we see patients who are coming from periphery without even proper mapping of the disease, and they come up with a tracheostomy, and when we map the disease and in our MDT, we usually, most of the time, we see that the patient, this was the patient who could have easily gone through chemoradiation and organ preservation. So what about these patients? Should we still advise them laryngectomy? I feel that they are the candidates who can be offered preservation.
Reevaluate them
So,
with the endoscopy.
Evaluation, proper evaluation and discussion in the MDT is most important. My question to Pankaj is, what about those select group of patients with lesions in the post-cricoid, maybe T2 lesions in the post-cricoid with positive nodes? Would you treat these patients with chemoradiations, or would you upfront offer surgery for this? They fall into hypopharyngeal group of cancers.
The post-cricoid cancers, be it T2 with node, they are primarily treated with chemoradiotherapy, because the only surgery that you have for them is total laryngopharyngeal esophagectomy with gastric pull-up or free jejunum, depending on the lower extent of the disease. So by and large, in our institution, we have very good results by giving CTRT to these patients. Though they are hypopharynx, they are treated predominantly by CTRT.
Any other surgeon on the panel having a different view? Would you treat this patient upfront by surgery, or all post-cricoids T2 N plus would be treated by chemoradiation in your book?
All post-cricoids with vocal cord fixation, with evaluation, with disease in the paratracheal groove will go for, if he is fit, the best treatment for him for locoregional control is probably primary surgery in the form of TLP and post-operative adjuvant therapy. There's no doubt in my mind when I say this. But having said that, I must say that it is a very morbid procedure. It cannot be undertaken very lightly, and you have a mortality of nearly 5 to 6%, which other head and neck cancers are not associated. So this is a very clear take-home message. If the patient is fit for surgery, anything T3 with a fixed larynx, with disease in the paratracheal groove. Now, what is the contraindication, you may ask me? If the disease in bilateral paratracheal growth, which do not allow you to save the paratracheal glands on either side, and this is a no-win situation. It's better to go for a non-surgical option.
So the point I'm trying to make is, if you select your patients well, you don't need to do salvage surgeries on those patients for recurrent disease or residual disease and for non-functional larynx, and that will improve the outcome of the patients. Let us go forward.
Sir,
and
just one quick point, sir.
Yes, Vishal.
So just one very quick point. I think we all, because of the RTOG 9111, have more started to indiscriminately use CTRT without any rationale of anatomical sites or anything. And I think that is something we should all incorporate. That is a speech therapist and rehab assistants to evaluate these patients for aspiration index, like what Dr. Shanai said about dysphagia index, and then objectively evaluate them. And I think that will give us more amount of objective data on this, sir.
Yeah. Ashish, you are there on the panel. So when you treat these patients with chemoradiations, what drug, how do you modify, or whether you use weekly cisplatinum or 3 weekly, does it make a difference in the toxicity?
Yeah, of course. Basically, the selection of the chemotherapy drugs depend on the multiple factors. And I think whenever we see the patient in our clinic, the patient's performance status, their age, the underlying comorbidities, the renal function status, whether the patient is able to tolerate the chemotherapy or not, and of course, the affordability is another consideration. So, if you look for the systemic treatment option, I think that could be a high-dose chemotherapy that is cisplatin. That can be a weekly chemotherapy, chemobiotherapy. It could be a combination of cisplatin with mometasumab. And the fourth option is just cetuximab. The patient is not a candidate for chemotherapy. So I think whenever we see the patient, I think these all factors we consider and we plan our treatment.
So, Sarvani, what is your preferred drug when you use concurrent chemoradiation? Do you use cisplatin 3 weekly at TMH or weekly?
I think there's some background noise is coming. Somebody can
mute.
Is Sarvani still there?
First, after the first randomized trial of weekly versus 3 weekly, we kind of tried to move to the 3 weekly regime. But what we realized was that there was still a group of patients who would not tolerate the 3 weekly regime.
No,
so now largely what we are doing is
weekly versus 3 weekly. What gives you the least morbidity?
We are using 40 milligram per meter square weekly in most of our patients. In some patients, when we do get a bed, we do use weekly, but there are the 3 weekly, but there is no definite or objective criteria except for the patient's functional status.
Okay.
Can I add to this? Yeah, I would like to just ask Sarvani, because the trial was done at her place with, I don't recollect the name of, I think it was a lady from medical oncology. And
Anita Narona.
Yeah, correct. And they showed that toxicity is considerable, but the control is much better with the 3 weekly group. Is that your final kind of take on it? Because control is sacrosanct.
Yeah, but what we need to remember is now we have the Japanese, the Japanese trial, which definitely shows that 40 milligram per meter square is not inferior to the 3 weekly regime.
Great.
And I think in the Indian setup, looking at something that we can do in the OPD, requiring less supportive care, will be much preferable. Yeah. And I think Ashish will agree with me.
Yeah. I wanted to ask you that question because from time immemorial, at Kidwai, we have been using 40 milligrams and we have been very happy with it. And we have been looking at it, whether it's cumulative dose versus the sequencing of the disease. But we found that, and we talked to people, the medical oncologists who are big names like Warburton and all these people, and they felt that as long as your total dose is somewhere around 600 milligrams in both the schedules, it should not make a difference. Whichever schedule is better tolerated by the patient is what is the better kind of option. So, did you agree with that?
Yeah, so what most people, what Ashish, I'm sure you'll agree that what most people would look for is a cumulative dose of cisplatin above 200 milligrams per meter square, and that also taking into account what are the renal reserves of this patient and the performance status. Ashish, if you would like to add something?
Yeah, I just want to make a correction in this. The doses of cisplatin which showing a survival benefit should be more than 200 milligram per rather than 600 or 400.
400 milligram per?
200.
This should be more than 200 milligram per meter square. So 200 to 210 is a cutoff. And I think some of the study it is more than 210. But 200 milligram per meter square.
The entire course 200 and 250. Is that right?
Yeah, but it's a body surface area. So what I'm trying to tell you, it's a 200 milligram per meter square.
So let us move to the first case that we have. The male, 52 years of age, T3N1, and he had a transglottic fixed right vocal cord to begin with, and chemo radiation was given, and he's post CTRT 9 weeks. And last 2 weeks he developed dysphagia, and he was on rice tube feeding. And he developed coughing and then a mild stridor for last 2 days. And this was the Hopkins examination, as you can see now on the screen. And you can see very easily that he's aspirating a lot of saliva. So my questions to the surgeon, starting from Saurabh, what do you think? What do you feel that this patient will need?
So definitely this definitely
how will you manage this patient?
This patient need admission in the hospital, and I will start. Yeah, so I will admit this patient, and I will start this patient with a fiber optic, definitely, which you have done. then I will start this patient on steroids, definitely. And I will see one day or 2 days how bad is the aspiration is. If the aspiration is bad and patient is stridor, we have to do a tracheostomy because that is a life-saving thing that has to be done. But we have to see the grade of the stridor also and the grade of the aspiration also. And then from that point of view.
Tapaswini, what will you do first?
So here, looking at your clinical history that you have given us and the picture that I am seeing, it's a grossly edematous larynx. I don't expect that this larynx can be preserved at any point of time. So I'm going to counsel him for a surgery, which would be not less than a total laryngectomy and a speech rehab with the prosthesis if the mucosa and the tissues allow us in the first setting at all. But if the mucosa is really edematous, we may not put the voice prosthesis right now.
Rajendra, can I add to that?
Yeah, let Uma make a comment.
Okay, please.
Yeah, I would probably go somewhere between what Saurabh said and Dr. Piswani said. I would not jump into a total laryngectomy immediately. Yes. I would initially give a trial of steroids and antibiotics. But one more thing I would add, definitely, although it's a little too early, I would definitely ask for a PET CT scan. And if a PET CT scan shows it's very conclusive that this is a relapse, and there is on the CT finding there is a tumor involvement and it is not just edema, then I would counsel him towards after probably a week trial of antibiotics and steroid, I would definitely counsel him for a total laryngectomy. Rather than do a tracheostomy and then do a total laryngectomy at a second stage, I would probably plan it at the same time in case the PET CT is highly favorable for a relapse. I wouldn't really go looking around to get a biopsy and confirm it.
Yeah, Vishal.
So the point I can see is that in these cases, like what Manoj sir said, we would definitely want to give a try with conservative method. We will also add aggressive speech therapy, swallow therapy, rehabilitation measures, as well as we will also, we see that in these kind of edematous larynx, they also have dysphagia and hence nutritionally are bad. So nutritional assessments and support is very crucial, sir, in addition to this.
Yeah, can I add?
Yes,
I would like to do a PET CT, and it's now nearly about 9 weeks, you said. So if you're having a residual disease, I won't wait. I would just do a tracheotomy, confirm the tumor, and then go ahead for a laryngectomy. I don't think you can do any form of partial laryngectomy.
Pankaj, will you do anything different, Pankaj?
So basically, I think the 9th week, 8 to 9 weeks for any patient after CTRT can be a bad time, and he can have all these symptoms of dysphagia, coughing, stridor, very common in those patients, especially if the disease choice was not good. So I will also not jump to going for total laryngectomy. I'll work up the patient, but I would first do a CECT chest or a chest X-ray. If the patient has developed aspiration pneumonitis, this is an emergency. I will have to do a tracheostomy. A Ryle tube has to be put, and then this patient has to be, observed for a certain period of time. 9 weeks again is a borderline for doing a PET CT, because if this is so much of inflammation and edema, all that, perhaps PET CT scan also may not be able to help. Maybe I will defer it for some time depending on the clinical picture. And if the PET scan shows something and this symptoms persist, then this patient has to be convinced about total laryngectomy. But many of these patients, if we do tracheostomy and Ryle tube, after a period of time, they recover and total laryngectomy can be avoided.
Dr. Shah, any comment? How would you manage this patient at Memorial?
You are mute.
Dr. Shah?
Okay. Yeah, I'm here now. You asked me to mute, so I decided to shut up, So I think there are two issues here. This is a young man, 52. We made a conscious decision 9 weeks back that we want to preserve his larynx. That was the decision either of the surgeon or the tumor board. So now we don't want to rush into taking out his larynx. If he's in airway distress, there's no doubt you need to manage him. If he's not in airway distress, I think the conservative observational approach is very appropriate. I don't think the PET scan is going to make a decision on him at this time. I think you may want to see what is going on. One day he may need to come to the operating room for endoscopy and evaluation. But again, I would make a conscious decision before taking out his larynx. The worst thing is you take out his larynx and there is no residual cancer. And you will feel very unhappy that I took it out in a big rush because he was having mild stridor. It is not uncommon in these patients sometimes, because it was a borderline case, that he may require airway support in a fashion of tracheostomy. The problem is, if you do the tracheostomy, very unlikely you will be able to get it out.
So, Sarvani, if this patient come to your department at TMN, Sarvani, what will you tell your surgeons? Do you expect this larynx to, suppose he is not having any disease, do you think this larynx will regain its function?
If I treated this patient, I would say that what I would do is essentially wait for some time before I knocked it off. One thing I would definitely do is,
why do you want to wait? Why do you want to wait? What is the philosophy?
Okay, so it's like this. We would get a PET CT done at 12 weeks because you've done an initial biopsy that is negative. I will not ask my surgeon to repeat the biopsy.
The patient has come after 9 weeks, post CTRT 9 weeks, completion of post CTRT is come at 9 weeks.
So you've done an examination, you don't see any disease, you do a PET CT, you again don't find disease. I will not biopsy this patient until and unless absolutely necessary. Maybe biopsy once to prove that there is no disease. But if that biopsy is negative, we will definitely not repeat biopsy, because from our own experience, we find that this leads to or actually exacerbates chondronecrosis. That's the second thing. Third thing is, if this patient continues to aspirate, then I will have to put in a Ryle's tube and the tracheostomy, of course. But I may again then counsel the patient and decide on whether to do a laryngectomy or not, especially if this patient is negative. And in the meanwhile, do conservative management with the use of vitamin E and pentoxifylline. We've done that in a few of our patients. It takes time, but we have to watch out for aspiration. And of course, the patient has both tubes in situ.
I think the critical questions that we need to answer is whether this patient has disease or not, number one. Number two, whether patient has got severe stridor which requires emergency tracheostomy or not. So if a patient has severe stridor, then there is no doubt that this patient will undergo tracheostomy, and then you can do everything later on. If patient has got mild stridor, which can be managed by antibiotics and steroids and all, you can always put a feeding tube and then wait and do a PET scan also maybe a week later. So is that the approach you would take, or then the question is patient going to regain the function or not?
No, see, there are two.
Yeah. So I feel we should wait for at least 12 weeks before taking this decision. They are likely that the edema will subside over this time. And if you have given a trial of steroids, in fact, sometimes they work wonderfully. And most of the times, if there is mild stridor, most of these patients, they recover.
Toprani, I would say one important stress is that you must have a tissue diagnosis before you remove the larynx. You must have a tissue diagnosis, whether it's 9-week or 12-week or 16-week. You must have a tissue diagnosis unless you have a totally dysfunctional larynx, a tracheostomy, a Ryle's tube, or whatever it is.
What I'd like to say
Dr.
is
Toprani is that I feel what Sarvani said, Dr. Shah said, that PET scan is not going to help us. We know that this is too early for us to have a disease which has come back. If at all, it is a residual disease. But I think what we are forgetting is the rehabilitation. This patient needs swallow rehabilitation. Patient needs to understand how to swallow in order to reduce the dysphagia and the cough. So I think more of stress should be during radiation. This patient should have received rehabilitation. After the patient comes to you, don't jump the gun. Put a Ryle's tube, stop oral feeds, see that the patient gets proper swallowing therapy, a chin tuck maneuver. This patient needs to be evaluated with a modified Bayesian swallow. Then after another 2 weeks, 4 weeks, the patient should be re-evaluated. So I think proper rehabilitation maneuvers and seen by a proper speech and language pathologist is very critical here.
So the message is very loud and clear that don't rush in to do a total laryngectomy for such patients.
Yes.
Just wait and
And
watch.
another thing that I'd like to say, another thing, if I could please make a point, is that do not repeat biopsies again and again, because that really predisposes to chondronecrosis. And we've seen it, because though we see there is this clinical thing of it could be disease. Yes, persistent laryngeal edema up to 6 months, you may have disease. But then at 3 months, if you had a negative biopsy, don't jump in to repeat the biopsy again. Wait for some time, give it some time to settle down.
This patient is not able to swallow, so, and you don't expect this patient to swallow for a couple of weeks. Would you put a feeding tube through rice tube, or would you advise a gastrostomy or PEG?
Either of them. Either. It could be either an NGT.
What is your approach? When do you advise for PEG and when do you advise for a rice tube feeding?
Okay, so what we do is typically, if it has to be a long-term feeding solution, then the preferred modality is a PEG. But if it is going to be something that is short-term, it would be an NG tube.
And how would you treat this patient? What drugs would you use? How would you treat this patient? Would you use antibiotics? What antibiotics? Would you use steroids? How long?
So the point of steroids is, I know a lot of you said steroids, but how long would you use the steroids? That's my first question to you. Also, this patient, no. So that's why we use steroids, but the use of steroids is very limited. We try to use some enzyme preparations, but again, that is empirical. The other thing that we've used very often in this is that we sometimes use a combination of pentoxifylline, that is Trental, 100 milligram 3 times a day, and capsule Evion, that is vitamin E, once a day. And of course, if the patient has any signs and symptoms, some kind of pneumonia, we would give antibiotics for a limited period of time. But all through this, the patient has to practice active swallowing therapy.
And what are the chances that this patient will recover his function?
I want to ask Sarbani whether this patient will be under the hospital care. Will she be under hospital care, and or can he be looked at by his personal physician at home?
No, this patient is not going to stay with us in the hospital. No, the patient is advised. The patient will go home with all these instructions and will come back. Because
Can you predict what will happen to this patient? Can you, Sarbani, predict how this patient will behave, whether he will regain the function or he will undergo a total laryngectomy?
Then you will open the Pandora's box.
No, so I'm going to be very candid about this. A patient who has undergone a tracheostomy post CTRT, it's only about 25 to 35% of patients who can be weaned off their tracheostoma after this entire exercise. They will remain to be long-term tracheostomy dependent. Now that is something that we understand. We have to accept it. That's how it is. But yes, if the patient is persistently aspirating, is developing repeated episodes of pneumonia, even after 6 months of undergoing all these conservative measures, I would have to counsel the patient for a salvage laryngectomy to take care of this, because it's then going to be life-saving.
You will not jump on to total laryngectomy. No. You will give him all the chance to preserve. And what about your experience of using hyperbaric oxygen?
We do not use hyperbaric oxygen that often. We've actually relied more on these the pharmacological management of these patients. Occasionally in patients who've had obvious chondronecrosis with a fistula or a sinus in the neck, we have used the typical Marks regime for a hyperbaric oxygen, but we've not used it very often. I just now remember only 2 patients whom I've used it.
Okay.
What was the result, Sarbani?
So in one patient, there was a definite improvement, and he actually still comes on follow-up. The larynx is intact.
Okay.
Not had to operate. So that's my hope,
Okay.
Dr. Rajendra?
Let us go to the surgical complications now following.
I think Dr. Swini has a question too.
Yeah.
Dr. Swini has something to say.
I just wanted to comment, Dr. Rajendra. We were talking about biopsies being done. Am I being audible?
Yeah.
Yes.
Yeah. So if we look at this particular picture that you showed, the larynx is quite edematous. Even if this patient had a disease, it would be deep inside, it would be submucosal, and it wouldn't be easy to biopsy. I think the other thing that if at all we had to prove, an image guided sort of an FNAC would be more something which would be more practical. If at all we had to prove to sacrifice this larynx, an image guided or a CT guided sort of an FNAC to prevent even the danger and the risk of chondronecrosis. So I just wanted to comment, and if anybody wants to, because taking a biopsy in an edematous larynx is not an easy job. You have to really go and deep inside it would be situated. So a deep biopsies would definitely would somehow 5% chance of getting it into a chondronecrotic state.
Dr. Tapaswini, this
Right.
is lying just inner to the inner chondricle.
Let us proceed further and talk about the pharyngocutaneous fistula following surgery. Now, there are some preventive measures that a surgeon can take. My first question to all the surgeons is, would you do an elective neck dissection for a patient who has undergone a post-chemo chemo radiation and PET scan is negative? Pankaj? Because there are a lot of studies which say that combining total laryngopharyngectomy with a radical neck dissection or an elective neck dissection unnecessary would increase the chances of a pharyngocutaneous fistula. So you must plan your surgery properly. So would you do an elective neck dissection if the PET CT is normal post CTRT?
Hello.
Vishal or Uma, anybody can answer.
So, yeah. So, if I have to see the primary disease, where the primary disease was earlier than chemo, then before the chemo RT. If it is a transblotting and involving the supraglottis also, definitely the elective neck dissection should be done in this case. Even after
And also in
therapy.
yes, piriform fossa, you should do a neck dissection.
Any other views from the panel?
So from the Tata, there is a study that they have found very small number in the elective neck dissection, the nodal disease after the salvage laryngectomies. But that also depend on the where the primary site was. The primary site, if it was supraglottis, definitely I will do at least the unilateral selective neck dissection.
Any other views from the panel? Anybody having a different view?
Yeah, if the patient had a preoperative N1 neck and he has completed CTRT and the PET CT is negative, I would not dig into the lateral compartment too much. I would probably explore the upper jugular and the mid jugular and the lower jugular areas. If I don't see any significant nodes, I would not try to dissect a full neck in such a cases, but I would do a thorough pretracheal paratracheal clearance, that's for sure. But I do not think if the N1 neck post CTRT PET negative, I don't think I would probably go into a full-scale elective neck dissection.
Pankaj or
Sir, one point.
Issue is of whether the patient was radiated or given chemo radiation. So when
chemo radiation is what I said.
For glottic, it is usually a small volume radiation. If it is a chemo radiation, then you would have to look at the fields of radiation. So it is very critical for us to evaluate what are the fields of radiation before you plan salvage. And I agree with Saurav that if you do a PET CT, I agree with Dr. Umanath Naik as well. If you've done a PET CT, there's a 96% negative predictive value that your nodes are negative. In literature, 17% of occult metastasis is seen in following dissections in all literatures where there's salvage laryngectomy. But we have to be critical and we have to understand what is the temporal relation of the chemo in your salvage, as well as whether you have a patient who has a possibility of or a recurrent disease.
So Dr. Toprani, so basically we must realize that salvage, the whole success of organ preservation protocol, whatever they have is because of the ability to do the salvage. So I completely agree that the surgeons has to be part of the entire organ preservation protocol from the day chemo RT is started, so that the salvage can be done in appropriate time. And salvage means that whatever neck nodes were there for which chemo-RT was given, the surgeon should know a priori when he is dealing with it. PET can certainly help, but when we are dealing with piriform cancers, like in India, in EMH, the maximum number of the total laryngectomy that we are doing for salvage are chemoradiotherapy for piriform cancers. There, the incidence of lymph node metastasis is much higher than the laryngeal cancer. So I think there is no straight jacket approach which can be employed. Multiple factors have to be taken in account, which radiology, preoperative imaging, and also assessment of the disease intraoperatively, so that this is the last surgery that is required and we can improve the outcome of the organ preservation protocol.
But my point is that you should not jump into elective neck dissection as a routine. You should, like you said, evaluate the patient and take a decision.
So that is what Uman asked, that the surgeons have to be involved in the organ preservation protocol from the day one, the patient when he starts getting the treatment. Problem happens when you have seen someone else has done the radiotherapy, someone else has done the evaluation, and then you are faced with the patient who you are seeing for the first time.
So we have another case for discussion. A 64-year-old male with a T3N1 larynx was treated with chemoradiation and he had recurrence and has undergone laryngectomy with a TEP. And this is a post-op day 7. He develops pharyngocutaneous salivary leak. And he was managed conservatively till the 14th day. And this is the picture on the 14th day. So Saurabh, what do you make out of this? The negative suction drain was removed and a corrugated drain was placed. You can see the TEP still, the process is still there.
Yeah, yes. So this patient definitely,
the upper skin flap is necrosed partially.
Yeah. So this patient still has fistula, most probably, and this skin part.
This is after the debridement. This is on the 14th day. The skin is debrided, and you can see the residual neopharynx there.
Yes.
Did
so
did the patient have a PM facial flap or not? Did the patient have a PM myofascial flap?
No, this was just
No.
a primary closure.
So this patient will need a PMF flap at least. PMMC, I difficult for the 40 day to suture the PMF flap here. I think PMMC flap here. The skin part is difficult to suture on the mucosa here, but definitely.
So when you do that, on what day you will do it?
You will do once the infection settles down.
Yeah. So I at this time I will not do it. I will wait for 2 weeks, at least 2 or 3 weeks, when the infection will settle down with the antibiotic and patient nutritional status will be little better. At that time, we should attempt the reconstruction part.
What are the other views on the panel? Any different views?
Can I intervene?
Yes.
Yeah, so, when we talk about complication symposium, our focus is prevention as well as management. This patient had a chemoradiation and the salvage laryngectomy was done. I would strongly suggest that any salvage post-chemoradiation laryngectomy, we must put a pectoralis major flap, even as an onlay, even if you are able to do a primary closure. An onlay flap of pectoralis major will bring a new blood supply to the area, and it's not that by Devendra's paper we know that it may not reduce the fistula rate, but it will definitely reduce the complication rate in the sense of the severity of fistulas, and conservative outcomes will be much better by doing a onlay pectoralis major. So my point is that for a chemoradiation salvage laryngectomy, I would put a myofascial flap as an onlay, even if I am able to get a proper primary
My question
closure.
to the panel is, do every one of you on the panel put a onlay PM flap following total laryngectomy for a laryngeal cancer, or do you consider it as an option for when you do a partial pharyngectomy also?
Yeah, can I answer that question and also talk about the case which you spoke about?
Yes.
Now, I absolutely agree with Kaustubh that we have to put a PM myofascial flap, especially if you are doing a salvage surgery within 1 or 2 years after post-CTRT, irrespective of whether it's laryngeal cancer or hypopharyngeal cancer. Now, in this particular case, which you have spoken about also, The management of the patient will be different if I have already put a, that's why I asked you whether this patient had a PM myofascial flap or not. If he already has a PM myofascial flap in place, I may give conservative management some more time because I'm not worried about the carotids as much or the jugular bleeding if a muscle flap has covered the entire area well. However, if this patient, like you said, has no PM myofascial flap, it would probably, I would get into surgical exploration and putting a PM myofascial flap and closing the fistula much earlier than I would otherwise.
Dr. Toprani, I think we are missing a point here. This patient has underwent CTRT. If this patient has underwent only radiotherapy, there the chance of fistula are lesser. Even in the literature, the chance of fistula rate with the radiotherapy failure only radiotherapy failure are only 10 to 15%, while the chance of fistula is around 30 to 40% in the CTRT. So if the patient has underwent only a small field radiotherapy for the carcinoma larynx, T1, T2, in those cases, I will see what are my mucosal. But in the CTRT patient, definitely we should do a only.
Dr. Toprani, I have a suggestion. You can, once you have exteriorized the fistula, it is a good idea to suture the skin and midline skin to the fistula and make the fistula right in the center. Make it drain only in the center. And once the infection settles down, then you can use a modified Wookie's flap and put a pec major on top of it. And the issue of taking stitches will not there because all round it will be having the neck skin. I wonder whether you have understood it. I would take a stitch and stitch the lateral end of the fistula, which you have shown in the second slide.
The fistula, and then you, how will you cover it with PM flap?
Yeah, so then afterwards, after the infection settles down, you again make a circular round the neck skin, elevate this neck skin a little bit, 1.5, and then put a pec major on that. And on the external surface of the pec major, you put a split thickness graft. That's perfect. It takes all the time.
We have tried this Wookie flap couple of cases. The problem has been the patient has had a lot of dysphagia problems post-op.
Anybody would use a free flap to cover this fistula?
It is a problem because you may have vessel depletion. Vessel depletion may be there. Vessel thrombosis may be there. And we would advise this. In fact, we have done it once or twice only to regret it. And I would recommend a regional flap. Regional flap is the safest.
Because not only do you need skin, you also need some good muscle, which the pectoralis major can give you.
So I think the key points are that when you have a large fistula and when your carotids are likely to be exposed, you must intervene early and put a muscle covering as early as possible to prevent carotid blowout. Otherwise, for smaller fistulas, you can always continue your conservative management for a long time if your major vessels are not exposed. But in this patient, probably a PM flap is a better option rather than a free flap. So all of you.
Toprani, can I just comment?
Yes, Tapaswini.
Yeah, so since this case that we are looking into is a post-CCRT and has developed a pharyngocutaneous fistula, so thinking that he would be managed conservatively is of course a very wishful thinking, because most of the salvage laryngectomies, this sort of a fistula which has developed post-CCRT, figure of around 16% of them, they only get managed conservatively. So we are already seeing a flap necrosis, skin flap necrosis, and a lot of avascular necrosis of the tissues would be happening at the same time. So it would be wise enough that the surgeon gets geared up and prepared that he needs to intervene, but when to intervene is also a very the correct decision would be when to intervene. So one must let him to have a good course of antibiotics, and so that the bed is ready for the next flap to be taken up, so that this flap that you are going to use should not be again a mess and a failure.
Yeah. So the next complication that we face in as a late complication is a post-laryngectomy stricture, and this is also not a very uncommon complication, particularly if partial pharyngectomy has been done. So my question to the panelists is, how will you prevent it at the first time when you are doing the surgery?
Yes.
How will you prevent having an having a stricture in a long term? When you do the surgery, at the time of surgery, what decision you will have to take to prevent this stricture formation?
No, I think you need to consider right at the outset a augmentation PMMF in case you have inadequate pharynx for closure. So already I think Prathamesh has made it 2.5 centimeters without stretching and 3.5 centimeters with stretching. Or I say, if you cannot loosely wrap around a 16 French Rice tube. If you cannot do that, it is always better to do a patch pharyngoplasty right at the outset with the skin inside. Skin inside. And if you don't have skin,
how many would you use a free flap to augment that?
Well,
I think a free flap in certain situations, a free flap may be considered superior to a PM patch, because you don't have that amount of bulk. If you're using a small radial forearm, your closure will be much better rather than using a bulky PM MC flap for a patch. So I think there are certain situations wherein a free flap, such as a radial forearm flap, may be a better alternative. If it is only a patch, not if it is tubed. If it is tubed, of course, we should go for jejunum. But in case of this, I think radial forearm may have its.
Dr. Toprani, so
if you use a radial or an ALD, how do you monitor these flaps post-operatively?
So there are two ways to monitor. One is to the fiber optic endoscopy. You can see the color definitely. There is no problem. Exactly. Otherwise, you can make a patch, a deepithelialized patch, which can come outside on the skin, and you can monitor from that also. But my point is the first one is, if it is a piriform sinus tumor or posterior pharyngeal wall tumor, and you are in a doubt from the beginning that it will be a total pharyngectomy or partial pharyngectomy, you have to be ready with the free flap, at least in those conditions beforehand.
Yeah, you can also make a circumferential defect. You can also construct with the PMMC also, if you are not equipped to do a free flap.
Dr. Toprani, can I just comment?
Yes.
Dr. Toprani, can I comment?
Yeah, go ahead.
See, as we were looking at the various studies which Prathamesh has quoted and Dr. Ashok also, that if the length, the dimension of the leftover mucosa is approximately around 3.5 centimeter, and you can close it rightly on your Ryle's tube. But what I feel in salvage situations, the tissues may not be that pliable. It may be a 3.5 centimeter, that dimension that we are talking of, it may be there with us. But if the tissue is not pliable and is really edematous, I think it's always a wiser decision to use a patch than to just close it primarily and put in a...
No doubt about it.
And also the other thing that I have seen... The other thing that we also see that the larynx in different countries is so variable. If you look at a larynx in a European, it is quite a wider larynx. And so this 3-dimension may not be something that which is be applicable to people at any different, in different parts of the world. So what our decision, how we take it in our institution is we measure it on our index finger. We put it into the pharyngo-esophageal area and then try wrapping this mucosa around the index finger. So if you can do it gently and if you can do it with ease, probably this amount of remnant mucosa is good enough to be primarily closed. That's how we look into it.
Dr. Mudit has asked a question, when do we reoperate after a PC fistula? So probably you have given an answer that once the infection settles in, then you put a flap to patch it.
But sometimes,
so Dr. Toprani, if the fistula happens on you see, and the first day you see that is the major fistula is there, post-operatively, you have to go intervene on that day. If it is in the within 24 to 48 hours, then you do not have to wait for 7 days or 10 days, or means 2 or 3 weeks. But if it is a delayed fistula, 7 days after.
Saurabh, why would a major fistula happen on the first day?
So it's very rare. It's very rare, but it can happen sometime. It's happened.
Pankaj,
Technically, you
with
won't
me
call it a technically you
in
won't
last
call it
10
a
years,
fistula
but
because
I
it's
have
not
to intervene
communicating.
very early.
Pankaj,
No,
can
no,
you
sir.
comment on what Saurabh is saying? First day fistula. I have not seen till now fistula happening on the first day. So there
Dr.
must
Toprani, it is primarily a surgical error. So
Yes.
there are institutions, where the hypopharynx is being closed by the residents. And there are many who would not have had been trained as to what is the apt surgical closure of the hypopharynx. Because to be honest, it has happened with me, and it has been me as the surgeon when I was as a trainee. So it was right on the day one that we saw that the salivary leak into the drainage tube. So as we grow, as we mature with our surgical skills, of course, then you get to see it much lesser. But
So,
it's
Pankaj,
primarily a surgical
what do
error.
you do, Pankaj, when you see this kind of a fistula on the first day? Pankaj or Prathamesh?
I think he has left for the meeting.
I think you get a new residence.
Yes.
And whatever be the fistula, if it is first day or fifth day or 10th day, I think a conservative management is the goal of the treatment. Unless you are very sure that half of the pharynx has been left open, then that's a different situation.
So I
But
think
if it's an early fistula, Dr. Toprani,
couple of points here that it depends on the size of the fistula, it depends on the remnant mucosa that is remaining still inside, and it also
how would you know? How would you know what's going
we
on
do
inside?
gastrographin test and figure it
and
out.
it
Sir.
also depends on the overlying skin. So, but the kind of fistula that Saurabh is describing on the first day, probably I would re-explore and see what is going on and take appropriate action. But I will be prepared to do a flap when I re-explore any patient.
Yes.
So,
Dr. Toprani, I have a question with Dr. Prathamesh on his presentation. He said there are two type of things. One is for the stricture. If there is a 1.5 centimeter unstretched mucosa is there, there will be no stricture. But if there is a to prevent the pharyngocutaneous fistula, there should be 2.5 centimeter unstretched mucosa should be there. So what is his policy?
Saurabh, what we are
Yeah.
following is a 2.5 centimeters of unstretched mucosa. 2.5 centimeters of unstretched mucosa. So that is whether you. So the issue is if you have a fistula, it will cause a stenosis because of the healing. If you have not closed, if your closed it too tight, like Tapaswini said, if you put a finger in and you wrap around it, and it is very snugly fitting, that patient can also have dysphagia. So you need to evaluate if it's a post-ED matters, post-CTRT ED matters mucosa, you should put a patch. And there is enough literature. There's a good review which all of us should read, which tells us about whether you should put a free flap with a muscle or without a muscle. So this is by the HNS microvascular reconstruction consensus, and they found that if you have put a patch without muscle, you tend to have a better, more pliant pharynx. The swallowing is so, but this is contradicting it for speech. When you looked at speech, the one which was with muscle was better. So we really, what the bottom line is, free flap is a good reconstruction plan. If you have a patient who's very thin, who's got a mucosa, PMMC without much fat, that will be a good pliant reconstruction. And this, when you look into the PMMC also, there has been a very unique reconstruction method done in Japan, where they put in a split skin graft on the muscle, and after 2 weeks they went ahead and used that patched PMMC. So now you have a very thin pliant tissue, which is a skin, so it will not cause stenosis. And now you have the muscle as well, which is more pliant to suture. So you can make it.
Let me
put a nice patch of it.
Yeah, let me go to the last patient for discussion. 44-year-old male with who has undergone a total laryngectomy with post-op radiation and a DEP also, and he presented to the ER with coughing and aspiration. And this is the video of this patient. And you can see this same patient with a leak.
It's a central leak, it seems.
It's a central leak. So, Vishal and Uma, between both of you, what do you think has gone wrong? How can you prevent it? And what do you do to correct this problem?
See, this is a problem we frequently face. And every time you don't have to jump to the conclusion that the process is always gone. A lot of times we see there is a temporary situation in which for some reason the wall doesn't close fully, either because of some phlegm which is stuck there or some crust which has formed between the wall and the junction. So what I generally do when a patient first reports with this, and it is the first time, we ask them to do certain maneuvers like using the Provox brush vigorously a few times, and also making him blow hard or cough with the finger, with the stomach closed, which dislodges any problems due to which the wall may not be moving. And then you give him a trial of swallowing few times. And just if it is just an initial episode, you kind of give him a couple of days to see if things settle down. And surprisingly, quite a good number of these patients settle down with conservative management. And then the wall again starts working. But however, if there is more than 6 months or a year since the processes was put, and there is a persistent central leakage, only option you have is, of course, to change the wall.
Yeah, but do you admit those patients?
So what about putting a what do you call
you can put yes, you can put a plug. You can put a plug.
Yeah, you can put a what do you call it? In plumbing, you use it. It's called a
Provox
plug. It's a collar. Yeah, collar. It's a collar. It's a silicone collar, which will give the depth between the tracheal surface and the posterior aspect of the wall.
That is what periprosthesis is.
Yeah, that is only for peripheral leakage, not for central.
Yes,
that is for peripheral leakage.
Yeah, peripheral leakage.
So, one point I wanted to add was,
yes,
I think to add to what Umanath sir said, there are patient-related factors, there are prosthesis-related factors. Now, the patient-related factors, like what Dr. Umanath said, like the prosthesis-related factors, sometimes it could be because of some kind of food particle or plug that forcibly opens that area and keeps it lodged. So by cleaning it in that area, you dislodge it, you clean that area. You can ask the patient to have a little soda so that if there is any particle stuck to the prosthesis on the inner side, it can get cleaned up. There are prosthesis-related things, or it could be a mechanical damage. We know studies published that about 15% of them within the first 1 month can actually have this intra-TP leak, which are prosthesis related. And if it's a mechanical damage, the only answer is replacement, or like Dr. Shanai said, to put a temporary plug. The patient related factors, a lot of the time we see is related to a tight closure. If it's a piriform related cancer wherein you have done a primary closure and the area is narrow, then naturally because of the high pressure of the esophageal region, you will end up having some kind of
suction.
Yes, sir. So that could also contribute, in which case it even after changing it into a new process, you may still see some kind of persistent intra-TP leak because the pressures there are very high.
So how do you evaluate that?
Dilate it.
So yeah, I think rightly
you
so.
can't do anything. You need to make them swallow, and probably you can inject some Xylocard in the PE segment.
No, you can do dilatation. You can do endoscopic dilatation. A lot of times, like Vishal said, endoscopic dilatation of a stricture reduces the leakage through the processes.
Correct.
Okay, this is Vishal. This is another patient. This is another patient who presented to the ER with the wall almost extruded.
Yeah, it's coming out.
Yeah. This is because of the processes which are too short.
Yeah. So this is too prestige is very. It gave away the of the prosthesis is very hard, and the mucosa, and you have with a catheter or with, and then put the.
Your voice is breaking up.
Yeah. Okay. Can I answer this?
Yeah.
Yeah, go ahead, Naik.
So one of the things to prevent this problem is to make sure that you assess this. The moment a patient tells you that he's having difficulty in speaking after you put a prosthesis, one should keep seeing them, because sometimes the first sign of this kind of a problem developing is that the patient starts saying, I have to use more strain to speak. So this is usually due to the processes being too narrow, too small, which causes granulations to form around it, and gradually the whole process gets extruded. So this is a problem of too short a processes. So right at the beginning, if you make sure that you replace the process before this problem develops, a lot of headache for the patient can be reduced.
Yeah, another thing is, probably you can inject some saline and you'll see the saline coming out through the other end, because this is, both ends are in the trachea. You can see it one end is being held by the artery forceps, and the other end you can see on the other side. So
it's got extruded.
Yeah, it's extruded.
It
has extruded and it has grown in the PO septum. So it has grown and caused granulations to develop there. So the granulation, this you'll have to take it out, let the fistula become a little small, and then put it after a couple of a week or something like that.
Yeah, so it's 8:35 and Dakshesh is pulling my leg, and he wants me to stop here. He has some questions from the audience to ask to you all panelists. And to summarize, we must understand a message to be given to the audience, that we need to select our patients very properly for chemoradiation. We need to manage their nutrition very well. For surgery, we need to plan our surgery appropriately and avoid doing unnecessary radical neck dissection concurrently with them. We need to have a meticulous surgical technique with a lot of tissue respect. We need to close our defects well. We need to appropriately use flaps at the first time, and we need to understand how to when to anticipate and diagnose the fistula as early as possible and manage appropriately. And then the issues of TEP. We need to do a lot of TEPs to be experienced enough to tackle these complications and treat these complications. So with this messages, probably I will end our panel here. And thanks to all the panelists for your active participation. I hand over to Dakshesh for having some questions from the audience. Dakshesh, over to you.
Thank you very much, Dr. Toprani. And I guess in a Q&A box, many of the questions have been answered. And thank you, Dr. Sarbani, for answering most of the questions. She has answered a lot of questions in the Q&A box. There is one question which is commonly asked by Dr. Mayuri and Dr. Abhishek. The question is common. They says that more of the patients are coming with borderline renal function who need CRT. So what are the views on having NACT followed by RT only, or cetuximab with RT versus carboplatin with RT in those patients who have compromised renal functions? Dr. Sharbani, Dr. Ashish Kaushal.
Yeah, I think.
Ashish, will you take that question first? Yeah.
Yeah. So compromised renal function is basically it's very broad term. I would definitely go for the detail, whether it's acute or it's a chronic, whether it is associated with any comorbidities like patient is having any kind of long-standing diabetes and those kind of things. So there is two things to address this answer. One, if the patient is having a borderline renal dysfunction, I think still I would prefer a carboplatin. But if the creatinine clearance would be less than 30 and the patient is in no financial issue, I think the cetuximab would be alternative options to carboplatin.
I would agree with Ashish. And the thing is, actually, for our institute, it would become more of an affordability issue, because I think we don't have any head-to-head comparison also between carboplat or cetuximab. Either of them are viable options would be my answer to this question.
What about Sharbani, the Dahanka group's recommendation, and would you take that option of giving 6 days a week or something like that?
Okay, now see, the thing about you're asking then essentially about whether we would consider doing altered fractionation. So if you go by the March meta-analysis, it is hyperfractionated radiotherapy that has shown the best results. So if you have to do altered fractionation, yes, hyperfractionated radiotherapy would be the best alternative. Barring that, yes, of course, you could do moderate acceleration without dose reduction, which is essentially the Dahanka way. and that is 6 days a week. Yes, there is this option of doing it, especially in a person who's got a compromised performance status, because hyperfractionation for such a patient may also be a tall
Thank you very much. I
think there was a very interesting question. Somebody said, how would you decide whether to do surgery or do CTRT based on the nodal stage? And that's the question I didn't answer. I thought the panel should take up that question.
Yes, the question is, there is no name, it is by anonymous. The question is, how does a nodal status affect treatment decision for surgery versus CTRT? I did not take this because this was a treatment-based decision, not the complication-based. That's why.
I know, but it's a very interesting question. I'm sorry, Dr. Costa, but I couldn't help feeling that this question is very interesting.
No, I understand we are closing, so we can answer this question and we can then close.
Dr. Costa, I just need to add in this question because we have discussed all the T-related issues. So does your local treatment based on the nodal status also? Because we have not addressed the nodal status in our discussion.
There was one comment made by my professor of surgery 25 years ago when he was talking about cancers, about oral, basically head and neck cancers. He said, always treat the primary on its own merit. So I don't know whether today, after 25 years, that particular statement has any arguments, but I think that would be the basis of our thinking that ultimately the nodal status should not influence the management of the primary. But there may be exceptions.
Yeah, I do respect that. When current is N3 disease, I think we need to respect, we know the biology of the N3 disease, and I think before considering the local disease, I think that should be addressed.
Yeah, so, I would definitely agree to Uma and Ashish. And if the primary disease is a disease where we can offer an organ preservation by chemoradiation, previously people used to think about sandwich treatment like removing a nodal mass and then give chemoradiation or radiation, but that is outdated because today we have an excellent imaging tools like PET scan. We have quite a good intensity modulated radiation therapy which can boost the areas, and that's the reason why eventually a selective, super selective node dissection or an idosectomy might be offered if the patient has done well. So in that case, patient will have an organ preservation. So I would say that still we will go for chemoradiation even though the nodal status is something which is different.
Absolutely. I think nowadays CTRT has turned around the scene in the sense that what is radiocurable at the T is most often is definitely salvageable if it is present after the CTRT. So really, it doesn't lead to the failure of therapy and a regional failure. So I think except for the occasional N3 node, which is a different story, it doesn't usually go into organ preservation. They will probably go into other issues if it is indeed amenable to primary surgery. I mean, if the primary is amenable to primary surgery. So with these few words, I think I'd like to thank the Kaustubh and Toprani and all the team at Ahmedabad for hosting this wonderful meeting, and a great opportunity to meet a lot of people like Umanath and people like whom I'm meeting after ages. So thanks very much, and good luck on your
and across the oceans meeting Dr. Shah after a long time.
Thank you very much, Uma. Good to see you all.
Yeah.
Everybody looks healthy.
Thank you.
Yeah.
Thank you, sir.
You are still there. You are still there.
Yes, I have to stay because of you.
So just to remind you,
But it's daytime there. It's not as bad here.
You are right. It's Saturday morning.
Please give our regards to Jay Shah.
I sure will.
And all the gang at MSKCC.
Absolutely, no problem.
Dr. Shah will be there on the last, finale 6.0, which will be on 15th of August on salivary gland. So he will be there, of course.
Okay, great.
So
Great. Okay, guys.
Can I say last words?
Thank you, everyone.
Last words?
Yes, Dakshish, yes.
Thank you, few of the participants also, Dr. Elizabeth Aib, Dr. Deepak Parikh, Dr. Abhishek Vaidya and Mudit. They were active in the chat box as well, answering, asking and answering few questions. And we'll surely meet next week at 6 p.m. for the reconstructive surgeries complication, where the two lectures are being scheduled. One is the complication in the free flaps by Dr. Deepak Balasubramaniam, and complications in the local and regional flaps by Dr. Sandeep Mehta. Followed by a panel which will be conducted by Dr. Dushan Mandlik, and the panelists are Dr. Subramaniam Iyer, Dr. Prabha Yadav Madam, Dr. Akshay Kudpaje, Dr. Dhanusha Gohil, Dr. Amit Kairom, and Dr. Soumya Matthew. So it will be again a very interesting session next week on the Saturday weekend, 6 p.m. So I hope you will join us for that as well.
Thank you, Dakshish.
Thank you. Thank you very much.
Thank you. Thank you, everybody.
Thank you.
Stay safe. Stay well.
Bye.
Stay safe all. Thank you.